ટેસ્ટમાં પણ પ્રોબ્લેમ ના થાય ને એના માટે. હા, 2 મહિનાની તમને આપી દઉં છે. વજન વધ્યું છે એવું ખરું કે?
Yeah, it's okay, sir. We can see. Just change few more slides.
So now you leave screen sharing.
Big car with instrumental delivery is in.
Sir, stop screen sharing. We are going to start the inaugural function.
Yes.
Yes.
Yeah, we can see it. Fantastic.
Nilesh?
Yes, sir.
Let's start.
We can start.
Yeah.
Yes, sir. I'm making this session live.
Oh, yes.
So the session is now live.
Start the inaugural function.
Okay. So I'm Nilesh Darji on behalf of Corona Remedies and in association with State Organization of Gynecologists and Obstetricians of Gujarat, jointly with Ahmedabad, Gandhinagar, Mehsana, Palanpur, and Himmatnagar, welcomes you all in this Happy Learning Masterclass webinar series, which is the 132nd of its edition. So today's MOC for seminar is Dr. Suman Sinha. Dr. Suman Sinha is the president of Ranchi of Gynec Society, senior consultant at AH IVF and Infertility Center Ranchi, director Advanced Care and Maternity Center Ranchi, vice president SOVSI. He is also member of Urogynec Committee Foxy. Also got various awards like Foxy Dina Award 2022. Appreciation Award 2023 and Dr. Durusha Appreciation Award 2008. Also, she was nominated for MS Signature Award 2023. So, welcome, Dr. Shuman. Then our coordinator for today's sessions are Dr. B. Kalpana and Dr. Jyoti Banglawala. So, Dr. B. Kalpana is a course director for postdoctoral fellowship in endogynecology affiliated to MGR Medical University. She is a national coordinator for the Infertility Committee Foxy, chairperson for Infertility Committee TNFOG, also secretary for MOGS, and also got received various awards like Best Doctor Award by Dr. MGR Medical University, Golden Excellent International Award by European Continental University, and Medical Excellent Award 2018 from Governor of Tamil Nadu. Also received Best Medical Service Award from Madurai District Collector. Welcome, Dr. Then our second coordinator is Dr. Jyoti Banglawala. She is the secretary of IOGS, has very vast experience of 26 years and has published many papers and conducted various educational and awareness campaigns. She is also an executive member of IASEC and Breast Health Committee. She is the IMA representative for MTP Committee Indore, treasurer for IOGS 2019 to 2020. And also recipients of Prestige Wonder Foxian Award 2019. She has also got, she is also a recipient of Indore IMA Corona Warrior, which has been awarded by government of MP. She is also a recipient of Nari
બે મહિના
Award
પછી એકવાર
IMA
બતાવી
Indore
દો
brand.
એટલે અંદરના.
So now we are going to start our session with lightning of the lamp. to you, ma'am, Dr. Suman Singh.
Okay, stop the screen sharing. Yeah, thank you. Thank you, Nilesh ji, for the kind introduction. Good evening, everybody. Lamp lighting by our dignitaries brings blessings to our webinar as well as gives a spiritual touch to it. I, Dr. Suman Sinha, President Ranchi Society and MOC of Happy Learning Program, take the delightful opportunity to welcome all the dignitaries, our esteemed guests and delegates in the 132nd episode of Happy Learning Masterclass webinar series in association with Ahmedabad, Gandhinagar, Mehsana, Himmatnagar, and Palanpur Obstetric and Gynec Societies of Gujarat. Theme of the webinar, as we all know, it is mixed bag. Happy Learning webinar is the most apt platform for sharing and enriching knowledge. It is the brainchild of our program director, Dr. MC Patel, sir. His vision and dedication has brought us today to the 132nd episode. We are extremely indebted to him. Knowledge spreading through happy learning webinar goes to the last Foxian. This has been an incredible journey. All applause for our MC Patel, sir. I now take the humble opportunity to welcome our honorable chief guest, luminary speaker, teacher, and surgeon of par excellence, Dr. Atul Munshi, sir. Next, I welcome our revered guests of honor, Dr. UC Vasavada, sir, Dr. Mahendra Soni, sir, and Dr. Kamini Patel, madam, for gracing the occasion. I welcome all the eloquent speakers and moderators for very meticulously preparing their topics to enlighten us on the recent advances in the obstetric and gynec field. I welcome our knowledgeable speakers for accepting, knowledgeable chairpersons for accepting our invitation to chair the session with their valuable inputs. I welcome our dynamic panelists who are ready for the brilliant interaction. I welcome our conveners, Dr. Akshay Sasar, Dr. Sneha Bhuar, madam, and my friend, Dr. Asa Jain, for their support in making of this webinar. I welcome our coordinators, my friend, Dr. Kalpana and Dr. Jyoti Banglowala, for their support. I welcome our academic partner from Corona Remedies, Mr. Nilesh, for giving us this platform and helping us in making the flyers, and this he's conducting the Zoom platform as well. I now welcome all the delegates who have joined today, and I'm sure that they will return back with being enriched with the deliberations which are being shared here today. So can I have the CVs of our conveners, Nilesh ji?
Yes, ma'am.
So I take the opportunity to introduce to the gathering our conveners of today's webinar, Dr. Akshay Saha sir, Dr. Sneha Bhuar madam, and Dr. Asa Jain. So please show me their CVs. Dr. Akshay Saha sir is Associate Professor in the OB-GYN department of SBP Hospital, Srimati NHL Municipal Medical College of Ahmedabad, and his special interest is in high-risk pregnancy. Next, can I have the CV of Dr. Sneha, madam? Yeah, madam, as we all know, she has been the dynamic chairperson of Foxy Breast Committee in the year 2019 to 2021. Presently, she is Governing Council member, ICOG. She is executive member. Presently, she is chairperson of Medical Disorder Committee of AMOX. She has presented more than 300 talks in state, national, international conferences and has a huge experience of 30 years. Madam is not here, so I'll move to the next. Dr. Asha. Dr. Asa, yes. Dr. Asa is the elected member of Chhattisgarh Medical Council. She is presently Honorary Secretary of IMA chapter of Chhattisgarh. She is
Ma'am, this is an old and wrong CV. Just say whatever you want to say about me and let it go at that.
Okay.
This is
Okay, no
wrong.
issue.
She's a very good friend of mine. She has a very good academic background and she is updating all the subjects. Whenever we ask, is ready to help us. So all the best to Dr. Asha. So next, I would like you to introduce our program director, Dr. MC Patel, sir, for the official address. Over to you, Dr. Asha, and please show CV of Dr. MC Patel, sir. Nilesh ji, you have to be
Yes.
on. Yeah.
So Asha, no need to be in a detail.
छोटा सा बोलेंगे आपको भी.
Yes. दो
हाँ
तीन लाइन
सर
बोल
सर
दीजिए.
आपके लिए जितना छोटा भी बोलेंगे वो थोड़ा बड़ा ही होगा.
Thank you. Thank
It's
you.
our privilege, to actually introduce you. You who have brought all of us together, joined the whole country, and have been so consistent that you do one every week, and then if there are extra, you do extra in the week. So it's really hats off to you. So I will definitely say a few words. So it's my great pleasure to introduce MC Patel, sir. He is known to all of you, all of us, all of India. He was the medical legal committee chairperson. His tenure ended in 2013, but the work continues to this day. He was the vice president Foxy 2018, among all the other things that he has done, n number of conferences. And the most important thing is that he is always there for any medical legal need of any Foxy member, anytime 24/7. In his lecture, he always says, keep my visiting card under your pillow and sleep peacefully. So that really is the truth. Welcome, sir. And I hand over to you to give the opening comments.
Thank you, Asha, for kind words. It gives me immense pleasure to welcome you all on 132nd episode of Happy Learning Masterclass web series. I welcome Dr. Atul Munshi sir, who has kindly consented to be chief guest to bless us. Of course, he is a very busy person, and in our series, I could make him available this time. Last year, he couldn't join this webinar. But thank you, sir, for sparing time to bless us in this webinar. I also welcome guest of honor, Dr. Yusuf Asavada from Mehsana. He has also kindly consented to be guest of honor to bless the webinar. I also welcome Dr. Mahendra Soni from Himmatnagar. He is also one of our guest of honor to bless the webinar. And Dr. Kamini Patel from Ahmedabad. She is president of SOGO, and she is also to bless this webinar, because this is a part of SOGO activity. Today's webinar is a part of SOGO activity. So she is here to bless us for the same. I also welcome two learned speakers, Dr. Rohit Jain. He is going to discuss very important topic of instrumental vaginal delivery. Now it is becoming an obsolete art in our modern practice of obstetrics, but he is going to justify the subject today. So welcome, Dr. Rohit. I also welcome Dr. Murugesh Patel. He is going to speak about hysterolaparoscopy in infertility, and two learned moderators who are going to moderate very interesting panel, Dr. Parul Kutrawala and Dr. Manoj Pandya. Real labor room emergencies they are going to discuss today in panel. I also welcome expert panelist Dr. Bharti Rajsekhar from Hassan. She has joined this series. So welcome, Dr. Bharti. She is busy with one more webinar. She is moderating one panel. So as soon as she is free, she will be joining this webinar. I also welcome Dr. Rekha Rajendra Kumar from Bengaluru. She is also going to give her inputs at the time of panel discussion. I also welcome all the panelists from state of Gujarat and joining society. Dr. Anand Chaudhary from Palanpur, Dr. Rohan Patel from Himmatnagar, Dr. Ratnesh Patel from Gandhinagar, Dr. Viral Luhar from Gandhinagar, Dr. Neeta Thakre from Ahmedabad, Dr. Gunjan Badrakia from Gandhinagar, Dr. Kaushik Vyas from Ahmedabad, Dr. Naresh Prajapati from Palanpur, and Dr. Akshay Shah and Dr. Saswat Jani, both from Ahmedabad. and I put it on record. Dr. Akshay Shah has helped me a lot as far as today's webinar is concerned, not only from designing but execution of this webinar with, of course, Saswat Jani. I also welcome all the learned chairperson who have kindly consented to chair respective session. Dr. Mukul Shah, our senior gynecologist and ex-mayor and standing committee chair of Ahmedabad Municipal Corporation. So welcome Dr. Mukul Shah. He is going to give his inputs about instrumental delivery at the time of this talk. Dr. Pushpa Yadav Madam from Ahmedabad, Dr. Sandeep Patel from Himmatnagar, Dr. Yamini Trivedi from Ahmedabad, Dr. Bhavit Shah from Ahmedabad, Dr. Sapan Doshi from Himmatnagar, Dr. Dignesh Balakia from Palanpur, Dr. Mukesh Savalia from Ahmedabad, and Dr. Mukund Patel from Mehsana. I also welcome Dr. Sneha Buyar. Of course, she is out of country, but she is one of our convener. Dr. Asha Jain is one more convener, and of course, Akshay Shah is also there. I also welcome two coordinator, Dr. B. Kalpana and Dr. Jyoti Banglowala. Both are with this series since long. So welcome Dr. Jyoti and Dr. B. Kalpana. I also welcome Suman Sinha, who is Master of Ceremony for today's webinar. In era of COVID-19, where physical meetings were not possible, we four friends started this series, and goal was to just meet our Foxian friends on virtual ground and to say hello and to discuss some focused topic, to exchange knowledge was the goal. And ultimate goal was to check our knowledge and to check maternal mortality and infant mortality rate, because by 2030, Government of India and WHO has given a target that maternal mortality should be 76 and infant mortality should be 12. Of course, there are few states in southern India, they are having maternal mortality less than 30. But at the same time, there are few states who are still having maternal mortality near 200. Say, for example, if I can quote state of Assam, it was 225, but in last statistic, it has come down to 200 and now it is 195. Of course, Bihar, UP, they are near 200. Gujarat is doing well. Gujarat is 57. Maharashtra is also doing well, 47. But still, it is long way to go. And it is not one individual person's role, because on part of government, WHO, they are helping other way. All NGOs, federation like IMA and FOXY, and particularly obstetrician friends who are working in rural India, if we go join in hand, then only we can reach that goal which is given by government to have maternal mortality and infant mortality under control. So with this aim, we started this series, and now I am happy to announce that we are more than 7,000 members as far as our Masterclass web series is concerned. So with this aim, we have started this, and every time we invite 5-6 societies of respective state to join the webinar and to discuss important topic. So today's Ahmedabad, Gandhinagar, Mehsana, Palanpur, and Himmatnagar have joined this webinar. So I welcome President and Secretary of respective societies and all the delegates who have joined this webinar. So without wasting much of your time, welcoming you all to this webinar. Thank you very much.
Thank you, Patel sir, for your very lucid welcome address. Now I request Dr. Akshay Shah sir to introduce and welcome our chief guest, Dr. Atul Mansi sir. So,
Akshay.
is he here? Yeah. Dr. Akshay, are you there? Sir, who hai kya?
No issue. And anybody can take from our team.
Can I take the?
Oh yes.
Okay. So I have the delightful opportunity to welcome our revered chief guest, Dr. Atul.
Madam, in small only. Don't. Everything is not necessary.
2-3 lines only, sir. Just allow me to say, because others are waiting to hear. Director at Munshi Group of Hospitals, Ahmedabad. He has been former professor and HOD at GCS and NHL Medical College of Ahmedabad, Associate Editor to Journal of Midlife Health, IMS Representative to Asia Pacific Menopause Federation, APMF 2021 to 2022. Was Proxy Representative to SAFRON 2016 to 2017. ICOG 2014. President of IMS 2010. And has been President of Ahmedabad OB-GYN Society between 1995.
Thank you, madam.
So welcome, sir. So we are eager to hear from you your lucid words and kindly bless our webinar.
Thank you, Dr. MC Patel and whole team for inviting me for this particular honorable post. Happy Learning Masterclass 132 not out. IPL is going on. Anytime 132 is a very big figure and still it's going on. Program Director MC Patel and whole team requires a round of applause.
Thank you, sir.
From north to south and from east to west, whole India is covered by this simple man in white attire. I know Dr. MC Patel since many years, a fragile looking yet very strong, a man with determination, always ready to help at middle of night, as Suman has rightly mentioned. Wishing him success in all the fields, whatever it desires. Today's masterclass is equally interesting, mixed bag of variety of hot topics. And we have people like Dr. Suman Shiha, Dr. Akshay, Dr. Sneha, Dr. Asha, Dr. my colleague, Dr. Vasavda Sahib, Dr. Soni Sahib, and teachers of teachers, Dr. Pushpaji, Dr. Mukul Shah, and Dr. Yamini. This masterclass includes instrumental delivery by young enthusiastic Dr. Rohit Jain. I know him since long, and he always there. Whatever he takes up, he will do it the best of things. Today's lecture will prove it. Basic surgery in fertility, hysteroleproscopy, a very common thing. Everybody wants to learn it. By Dr. Competent endoscopist Dr. Mukesh Patel. Legal aspects of high-risk pregnancy by none other than MC Patel. He is known as man of legal speciality everywhere, wherever you go. An interesting panel on troubleshooting in labor room by Dr. Parulbe in sport person, Dr. Manoj Pandya. They are both of us, they are very favorite to me also. I'm sure at the end of this masterclass, as Dr. Sneha has rightly mentioned, all of us will be enriched by many aspects of obstetrics and gynecology. I wish all of you a very happy day, happy evening, and a lot of things as far as learning is concerned. Thank you very much.
Thank you very much, sir, for sparing time to bless us.
You are always there. I'll be staying there.
Yes,
I like to hear it.
Of course, you are always with us in any of our academic activity, and we are always blessed. Thank you, sir.
Thank you. Thank you.
Thank you, Atul Munshi, sir. May I request Dr. Asa Jain to introduce our guest of honor, Dr. UC Valvas. Sir. Asha?
Namaskar. So I welcome Dr. UC Vasavada, who's a gynecologist at Mehsana. He's the past president of Sogog and Mehsana Obstetric Gynec Society. He's worked as superintendent of Lions General Hospital, Mehsana. He has given a very, very short CV, but being the president of Sogog, he really must have done a lot more work than is actually displayed here. So we would really love to have your blessings for this webinar of Dr. MC Patel, sir, number 132.
Savda, sir.
Is it there? Please stop sharing, Mr. Nilesh.
No issue. We can proceed further accordingly.
Achha.
And whenever Dr. Vasavda sir joins, we will have his blessing at that time. No issue.
Okay, sir. So I request Dr. Jyoti Banglawala to introduce our next guest of honor, Dr. Mahendra Soni, sir. He is here.
Thank you. Thank you, Dr. Suman. And good evening, all respected faculties. And we welcome you all in the 132 edition. And today's our respected guest, Dr. Mahendra Soni. Sir has done MBBS in 1978 from BJ Medical College, Ahmedabad, Gujarat, and passed DGO in 1980 from BJ same college, and completed MD in 1981 from the same college. He is private practitioner OBGYN in the Himmatnagar, Gujarat, and he is the founding president of Gujarat, Himmatnagar Gujarat OBGYN Society. And he is the president of SOGOG in 1995 and participated in many national and international conferences and training, and hosted SOGOG conference in 1994 as chairperson. He delivered many lectures and chaired many sessions in the state and national conferences. Special interest, his area of interest is critical obstetric and infertility. He has been the member of many NGOs and social service organizations like Lions Club, ex-regional chairman in Lions Club International, and awarded oration at SOGO conference at Bhuj. And this is a very formal introduction, but we know sir through our Ahmedabad colleagues, our Gujarat colleagues, and whenever we meet sir is so humble, so gentle, and always welcome all the faculties. We are the witness for this, particularly last 3 years when we are attending SOGO. Sir are so humble to receive every guest of the outer state. Sir, we welcome you for the to giving the blessing to our webinar. Mahendra Soni sir. Dr. Soni sir.
Yes. Thank you. Thank you very much for kind introduction. I will just like to state that Dr. M.C. Patel and myself, we started our medical career together. And I am really happy today, Manu Bhai, that we completed 50 years of our friendship. We started in 1973 and this is 2023. I am happy that Manu Bhai is conducting 132nd webinar. And so proper name, that is a happy learning. We all know that learning should be always happy. And when it is a happy learning, then it becomes a real learning. Today's topic, I will say that in introduction, Manu said that obsolete art, but I will say that it's not obsolete art. Vaginal instrumental delivery. Even today, when the whole world is worried about increasing rate of cesarean section and everything, in that case, I will say that judicious use of instrumental delivery has definitely a place in obstetrics. And still there are teachers. Even in my today's practice, I am doing forceps with a very good results. So we should encourage our junior friends. We should teach them in various workshops, all these vaginal delivery. I will say it has got definitely place in obstetrics. Second, infertility and laparoscopy. It is now everybody's experience that we get many good results after doing a small thing by laparoscopy or hysteroscopy. So all the panel discussion by young gynecologists, I'm happy that there are 3 gynecologists from my society only, Dr. Sandeep, Sapan and Rohan. Again, I give all the best wishes to this whole program of happy learning and particularly today's program. Thank you very much.
Thank you, Dr. Mahendra Bhai, for sparing time. Of course, you are always with me in any of my activity, not only academic, but any of my activity. So, my pleasure. And you have rightly said that the generation, our generation, who are well versed with forceps, delivery, etc. But newer generation, they are for any reason, but not preferring to go for instrumental delivery. And that is why I specifically with it is vanishing art rather, not obsolete, but vanishing art. Yes. Yeah. Otherwise, we still today, I also go with forceps delivery in indicated cases. So, thank you, Mahendra Bhai, for sparing time. Yes.
Thank you, Dr. Soni. And now I hand over mic to Dr. Suman Sinha, madam.
Thank you, Suman.
Suman, ma'am. Suman, ma'am. Please display the CV of Dr. Kamini Patel, ma'am.
Suman.
There is some problem with her internet.
No issue, you can take over.
Yes.
It's my privilege to be a part of this wonderful Happy Learning series, that to 132 edition. great effort from our program director, who is a medical legal expert and ready to help each and every gynecologist. We all know about MC sir. And it is my privilege to welcome Kamini Patel ma'am again. Tuesday also we had Kamini ma'am in our series. It is our privilege, and we have really enjoyed your SAGOG conference under your leadership, and we need your blessings again for this second episode, which is associated with Gujarat societies. And Madam is holding the prestigious post of President SAGOG 2023. She was the president of she is the president of Ahmedabad, the UGC, holding both the responsibilities efficiently. She's a senior consultant, gynecologist, and fertility consultant at SIMS Care and Cure Hospital, honorary secretary of AOGS 2018. And she has been an invited national and international speaker, and also secretary in critical care, joint secretary AICOG 2016. She's into so many research work, various topics like estradiol, a predictor of mature oocyte retrieval, comparison of 3 different capacitating agents in IVF, sperm capacitation, DFI and sperm, calcium ionophores and sperm, everything on infertility that shows her knowledge and experience in infertility. She has published various papers, including role of nutraceuticals in women's health, obstetrics and gynecology, 2022, creatine, a wonder molecule, in prestigious journals, and also written various chapters in Foxy handbook, and she has also supported PCOS guidelines, contributor in ASCOG manual too, and she is into ISAR publications on stem cell therapy, and also acrosomal reaction estimate with flow cytometry. So she has got research in genetics too. You are in almost everything. Welcome, ma'am. We need your blessings and support for this webinar.
Can you see me?
Yes, you are audible
Okay.
and you are visible.
Yes, thank you. Because I was traveling, I've just come. Shall I connect in other? Yeah, one second.
You are audible.
Okay, I'll leave this and I'll connect on the laptop. 1 second.
So we can stop sharing, I think. Yeah.
Yes, sir. Am I audible?
Yes,
Yes, ma'am.
you are
Yes,
audible and you are visible.
Okay, chalu cha. Chalu cha.
Yes.
Yes, okay, fine. I'm sorry, guys and friends, respected faculties. I was traveling and I've just reached my center. So I'm really honored to be present today as 132nd webinar of our Patel sir and Dr. Suman. Really, I am overwhelmed by the perseverance of Dr. Patel sir and Dr. Suman, because it's too hard. I am noticing since past 2 webinars, it's very difficult to cope up at the same time, isn't it? But anyway, he has got a lot of perseverance, and Dr. Suman, really, I am really honored to be present here today at your 132nd webinar. Yes, Dr. Kalpana, Dr. Rohit, Dr. Jyoti, Dr. Pushpa, and I wish you all people, because today there are a lot of learned faculties and respected, our teachers are also here today present. And I wish all the best. And I'm going to be present here because I want to listen to today's panel. It is very important. And I wish you all the best and overwhelming today's webinar should be there. Thank you very much.
Thank you, Dr. Kamini, for sparing time. I know you are a very busy person as far as your practice is concerned and having some good post also. But still, you have spare time. Thank you. Thank you very much.
Thank you, sir. Thank you. Thank you so much.
Thank you, Kamini Patel, madam. And with this, we come to the end of the inaugural function, and we quickly move on to the academic part of our webinar. And for the first session, I invite Dr. Jyoti Banglowala to take over the
Thank you.
session.
Thank you. Thank you. Thank you. Sir, MC Patel, sir, shall we start, sir?
Oh, yes. Oh, yes.
With the blessings of all our elders, now we are going to the academic session. Our first lecture is Instrumental Vaginal Delivery by Dr. Rohit Jain, sir. Please display Dr. Rohit Jain's CV. And our chairperson, sir, Dr. Mukul Shah, sir. He is Chancellor IGNOU from Amarkantak. Our second chairperson is Dr. Pushpa Yadav, madam. She is from the NHL Medical College, Ahmedabad. Our third chairperson, Dr. Sandeep Patel, sir. He is President Himmatnagar Obs-Gynae Society. I request Dr. Mukul Shah, sir, to introduce our speaker, Dr. Rohit Jain, sir. And I request Dr. Pushpa Yadav, madam, to use introduction for this topic. And I request Dr. Sandeep Patel, sir, to conclude this topic. Please display Dr. Rohit Jain, sir.
Dr. Rohit sir has started his.
I think Dr. Mukul Shah is not seen. So Sandeep can introduce Dr. Rohit, no issue.
Please display Dr. Sandeep sir and Dr. Rohit Jain's CV, please.
And then Pushpa madam will have opening remarks of the subject, and then Rohit will take over.
Hello.
Sandeep
Yes.
sir.
You are heard.
Hello. Good evening, madam.
Yes. Please introduce our speaker.
Hello. Good evening, everyone.
Yes.
Good evening to respected faculties and delegates to this webinar. Dr. Rohit Jain, who is MD and FICS. He is working as Associate Professor and Unit Head in Department of Obstetrics and Gynecology, GMERS Medical College, Gandhinagar, Gujarat. He has been an invited faculty in many conferences and workshops and has many research papers in his credit. He is an academician and advanced laparoscopic surgeon and has special interest in ART. He is also awarded with Gujarat Gynec Excellence Award in West Zone Yuva Foxy 2020. Thank you, ma'am.
Dr. Rohit, you can share your slides.
Yes, Pushpa madam will have opening remarks about subject, and then Rohit can take over. Yes, Pushpa madam.
Good evening, everybody. Thank you, sir, for inviting me to attend this webinar. I'm really feeling very honored. This is a very good topic, and especially it is gaining much importance because the cesarean section rates have been increasing tremendously. In some of the centers, maybe the ratio of normal delivery is much less as compared to the cesarean section. And as all of you have said, it is a vanishing art, but definitely our generation can still bring it back, because one more problem that increasing cesarean section rates is now presenting with is the PAS syndromes, that is the Percrita syndromes. So it is not just the cesarean section, but a young lady losing her uterus in most of the times. So it is becoming very important that we promote instrumental delivery. Maybe the old era of mid-cavity forceps or rotational forceps would be difficult in this present environment of medical suits, but definitely the delivering a baby who with a which is beyond +2 station is definitely on. So I invite Dr. Rohit Jain to start his presentation.
Thank you, respected Pushpa Madam, for giving me this platform to start my presentation. Before I start, I would like to thank our Program Director, Dr. MC Patel sir, and other stakeholders of this unique learning platform. I extend my special thanks to our chief guest, Dr. Atul Munshi sir, today's chairperson, Dr. Vipul Shah sir, and of course my teacher, my guide, Dr. Pushpa Yadav ma'am, and dear Sandeep Patel sir. So today we are going to I'm going to talk about instrumental vaginal delivery. Just to share, okay, I would like to just feature on salient points that we need to address, rather than going into the history part and the types of forceps and types of vacuums available. We are all expert obstetrician. So I have skipped those slides actually. So to start with, instrumental vaginal delivery. Instrumental vaginal delivery is a vaginal delivery of the baby, which is performed with the help of forceps or vacuum device, and it's sometimes also called as operative or assisted vaginal birth. If you look at the prevalence, in developed countries, it stays as a constant rate of around 10 to 15%. But in underdeveloped countries, as there is now an epidemic of cesarean sections, and is probably is now considered as a lost skill. So as we go through the various literatures, it is very clear that the global trend of instrumental vaginal deliveries is declining. Great concern to all of us. Now we have considered a woman for assisted vaginal birth. It is very important to have good clinical judgment.
எங்க இருக்கீங்க டேப்ஸ் இல்ல இது நானே டவுன்லோட் பண்ணிட்டேன் அதெல்லாம் எழுதி ஒவ்வொரு எழுத்தா எழுதி வந்துருச்சு ஆடியோ கேக்குது வீடியோ திடீர்னு போயிடுது தெரியல.
The level of the presenting part can be divided as an outlet, low and mid cavity, so as to determine the choice of correct instrument. At the outlet, it means that the fetal head has reached the perineum and the scalp is visible without separating the labia, and rotation of the head is something less than 45 degrees. Whereas low in the cavity means that the station is at +2 station and the rotation is less than 45 degrees, but it can be sometimes greater than 45 degrees even. Whereas in the mid cavity, the head can still be 1/5 palpable and the station is from 0 to +1, and rotation can be more than 45 degrees. High, we are not included. High category is not included in the classification, as operative vaginal delivery is not recommended in this situation, where the head is 2/5 or more palpable abdominally and the presenting part is above the level of ischial spines. So now, if you look at the indications, broadly speaking, there are no absolute indication for an assisted vaginal birth. The most important part is very thorough clinical judgment of the situation, which has to be individualized. We know that birth needs to be assisted because of fetal or maternal indication. Fetal indications are always when there is an urgency to deliver the baby because of pathological like CTGs, fetal heart rates, and presence of thick meconium. For the mother, it is basically done when there is delay in the progress in second stage of labor. Like it can be maternal exhaustion or a maternal distress, and in situation where active pushing is contraindicated, like class 3 or 4 cardiac diseases, hypertensive crisis, myasthenia gravis, spinal cord injuries, and proliferative retinopathy. Contraindications for instrumental delivery can be divided into absolute and relative. Now, absolute indications are all that we do not anticipate a vaginal birth. For example, if cervix is not dilated, fetal position is not known, the head is not engaged, if it is a malpresentation, or it is a CPD, the most important part is all we know is inexperienced operator and does not have any knowledge and skills. And for the ventouse delivery specifically, it should be avoided at a gestational age less than 32 weeks, or we can use with a great caution between 32 to 36 weeks. There may be some situations where there can be relative contraindication. For example, if fetus has bleeding disorders like autoimmune hemophilia or alloimmune thrombocytopenia, where there are risks for fractures, or in the presence of maternal viral infections like HIV. Now, the safety criteria, it is the most important aspect of assisted vaginal birth, because recently there have been reports of traumatic births, which has led to neonatal morbidity and mortality. So the preparation of mother is that you have to do full assessment, which includes abdominal and vaginal examination to make sure that the baby is in the right position. The station is below the spine, the molding is not severe, the pelvis is adequate, and obviously the mother is fully prepared for the assisted birth. As I say, preparation of the mother is very important, because this procedure is cannot be a success without equal cooperation from mother, and for that she needs continuous support and information, advice, and very clear explanation of what is going to happen with her, so that she can make an informed choice and give an informed consent. For all the aseptic techniques, as we all are versed with, all aseptic techniques are to be ensured. The Foley's catheter before going for instrumented delivery is to be removed. The bladder should be emptied. And of course, there should be an appropriate analgesia. If it is an epidural which has already been placed, it's good enough. Otherwise, we can go for pudendal block or local perineal infiltration in emergency situations. The preparation of staff is again a very important point, because this is an intervention and we need the whole team to work upon. So it is not just only the operator who is going to do the procedure. It requires alert and prepared team as well. So the preparation of staff, we need to have a good neonatal team, labor room manager, a good in charge midwife, who can make sure the equipment is in the right working order, the light source is there, the woman is in it, she's comfortable, she's actually informed of the situation. So in case of emergency situation, you try to use vacuum device and which is not working, then it's going to create a lot of panic. So we can avoid such situations with the fulfilling these safety criteria. Let us just briefly go through the application techniques. Now, this slide shows the ideal placement of forceps. When forceps is properly applied, it is the biparietal bimalar application that offers uniform grip on the two sides. The sagittal suture bisects the shank, which is over the flexion point, about 3 centimeters anterior to the occiput. The patient is obviously given the dorsal lithotomy position, so that her buttocks are at the edge of the table, proper analgesia, preferably pudendal block with perineal infiltration. The left blade is held vertically in the left hand over the metal pubis. 2 fingers of the right hand are slipped alongside the fetal head, holding the vaginal tissues back, protecting the vaginal tissue all over. And the blade is then introduced into the left side of the maternal pelvis under the guidance of right hand. The blade is closely applied to the fetal head, gently guided by the right fingers to sit on the lateral side of the fetal head over the baby's ear. And the fingers of the left hand are next slipped along the other side of the fetal head. Right blade is always glided inside above the left blade, not from the below. If we try to apply from the below, it won't lock. So that is to be make sure. When correctly applied, as I said earlier as well, it is biparietal placement. The blades are articulated with ease. So the traction is in the direction of the pelvic curve and is synchronized with the contraction and maternal bearing down efforts. That is very important. We should not try to pull the baby with once the forceps is applied. Without pushing it. We must have at the start of the contraction, we must ask the patient to push down, and then we should pull the baby. Regarding ventouse application, it is again applied in the lithotomy position and is antiseptic solution, painting and dripping, and the bladder is empty. All the prerequisites for application of instrument, either forceps or ventouse, are fulfilled before the application. And a thorough examination to determine the station of the fetal head, that is important. Position of the occiput, suture line has to be determined. Assessment of the pelvis and extent of cervical dilatation made. Pudendal block preferably shall be given. Proper cup placement is most important determinant of the success of vacuum extraction. As we can see in this slide, the flexion point, it is a point that is the center of the flexion point is about 3 centimeters in front of the posterior fontanelle. That is where ideally the vacuum cup is to be applied. This is a slide showing the comparison of correct placement and incorrect placement of the vacuum cup. So once the vacuum cup is applied correctly at the flexion point, the flexion of the head is maintained and it is easier to deliver the baby out. So what we need to take care is to make sure that the metal and soft parts like cervical limb, vaginal rim, or vaginal wall is not included in the cup. When using rigid cup, vacuum is created gradually by increasing the suction 0.2 kilogram per centimeter square every 2 minutes until a negative pressure of 0.8 kilogram per centimeter square is reached. But all of us must be using a silicone cup, in that case we can gradually increase the pressure to the same level, 0.8 kilogram per centimeter square, over the period of just 1 minute. This is the gauge that different gauge of the suction machine that we come across. As we can see here, 0.8 is the maximum limit, that equals to almost 600 millimeters of mercury, and or 80 kilopascals if there is a kilopascal gauge in your machine. So 600, most of the machines, suction machine, we have millimeters of mercury. So we must not exceed the suction pressure, vacuum pressure, more than 600 millimeters of mercury. That is important. The traction should be sustained during the pains, and again, the same as forceps. The direction of the pull should be in the axis of the birth canal, and pulling, the higher the head, the more the downward should be the direction of the traction. It should be intermittent and coordinated with maternal expulsive efforts. Traction should be initiated by using a 2-hand technique. One hand can be kept over the cup of the vacuum, and another hand can be used for traction. Total duration of time recommended should not exceed 20 minutes. As greater the time, greater is the chance of failure. Recommended to avoid more than 3 applications to prevent complications. So this is a slide showing the technique of vacuum application. So what is failed vacuum extraction? The overall failure rate is around 17 to 36%. The head does not descend with each pull. Head is undelivered after 3 pulls with no descent, or after 20 minutes of procedure. The cup slips off the head with maximum negative pressure. What are the frequently occurring complications? Ideally, during antenatal period, the pregnant woman should be informed about assisted vaginal birth, because as I said, around 10 to 15% of the women are going to need some kind of assistance, and you should talk about cesarean section also during her antenatal visits of cesarean section about 20 to 25. That is the best time antenatally to talk about the risks and benefits of assisted vaginal birth. So she will be prepared for any such incident, and about the choice of instrument. But if you look at the figures, it is very clear that the vacuum is safe for the mother because it leads to less perineal trauma, less risk of tears, obstetric anal sphincter injury. But the forceps are most traumatic for the mother. They may be safe for the baby, but are traumatic for the mother. Vacuum has special concerns for the baby, such as risk of palihematoma, pleural hemorrhage, onset of jaundice leading to exchange blood transfusion, or therapies, specifically in case of preterm babies, where the vacuum or ventouse application is done before or under 32 weeks of gestational age. As you said, see here, most of the serious maternal complications do occur in case of forceps, like third or fourth degree peritonitis, extensive or significant vaginal vulvodynia, and fetal complications in case of vacuum delivery, like subepidural or subgaleal hemorrhage, intracranial hemorrhage, which are rare, injury of 6th or 7th cranial nerve, Erb's palsy, which are rare. Cervical spine injury are also rare. So the clinician has to make a balanced decision about the choice of instruments, keeping in view the risk profile of these instruments, so that one can actually get the best outcome for the mother and the baby. The recommendation, as I said, that assisted vaginal birth is now considered largely a skill which is not being practiced by our trainees, and it is skill which is not encouraged by the supervisors. So it is important that we ensure our obstetric trainees that they receive training in vacuum and forceps birth, including theoretical knowledge and simulation. The competency to learn, that is, competency should be demonstrated. They should demonstrate a competency in use of instruments before going for unsupervised assisted birth. And in any case, the complex birth shall be undertaken or shall be done by senior clinicians. Every assisted vaginal birth is an intervention, and it is emergency situation where you are assisting the birth for the interest of the mother or the baby or both of them. So it will include certain clinical governance issue. Therefore, it is important to have good documentation of the entire procedure, and the safety of the baby has to be ensured again, because if it leads to traumatic birth or leads to long-term disadvantage or harms to the baby, the obstetrician stands answerable. So certain things has to be done. For example, a good documentation of the procedure. Cord blood sample can be taken, blood gas analysis if you suspect fetal distress, to make sure that the baby was not hypoxic at the time of birth. Because if later the baby develops hypoxia, it may be related directly to an assisted birth. So any adverse related to an assisted birth pertaining to mother or the baby needs to be documented. That is very important from the point of view of risk management, so that all this assisted birth can be audited. It is very important because we need to improve the quality of care to our women and our neonates. This is only possible with regular audits. So all the good or bad that has been done in an assisted birth needs to be very clearly documented. It may trigger any incident report as a part of effective management, so as to analyze and determine what has to be done to improve our services and care. So my take-home message is the trend of performing instrumental deliveries is declining worldwide, and this downward trend is more pronounced in developing countries. What is more worrisome is the alarming rise in cesarean deliveries across the globe. The rising global cesarean section rate of 21% is higher what WHO has recommended, that is 15%. Therefore, reviving the practice of instrumental deliveries would be one of the options to counteract the rising rate of cesarean section. It is especially important when the option of instrumental delivery is preferred over cesarean sections in the second stage, which is more difficult and associated with more adverse perinatal outcomes. Thank you.
Dr. Sandeep sir, please, can you give concluding remarks, sir? Sandeep sir? Pushpa madam? Pushpa madam?
Yeah. Yes, this was a nice presentation of a topic which really needs for all of us to rethink and encourage. And as Rohit has rightly said, it has to be done at the medical college level, where the new entrants, the new consultants that are going to come out should be made to learn that this is not something that is to be feared, but it is a skill that needs to be redeveloped. So it was a nice presentation, and that's all.
Thank you, ma'am.
At present, there are no questions. Dr. Rohit, if we get any question, we will display at the end of the session.
Sure.
Thank you. Thank you, Dr. Rohit. Now we are moving to session 2, and it is hysterolaparoscopy in infertility by Dr. Mrugesh Patel, sir. For this, our chairpersons are, kindly display our chairpersons are Dr. Yamini Trivedi, madam. Yamini madam is professor and HOD LG Hospitals and NM Medical College, Ahmedabad. And she invited as faculty in many international clinical research conferences. And one important conference in San Francisco, USA in year 2007. She gave many radio and TV talks on maternal health and women health. And she got Best Professor Award by Gujarat University in 2012. She is MCI assessor since last 14 years. And she has been ethics committee member in as gynec expert in VS General Hospital, ethics committee member at AMCMET Medical College since 2010, member in Institutional Review Board, NM Medical College. Welcome, Yamini madam. Our second chairperson is Dr. Bhavit Shah sir. Bhavit sir is owner of Karma Maternity Hospital, Ahmedabad, and trained in endoscopy from Taiwan, doing freelancing endoscopies and laparoscopies, oncosurgeon and urogynec surgeon, then more than 20,000 surgeries, running 3 months fellowship program, honorary endoscopic surgeon at Shardaben Medical College. He had many paper publication in national journals, faculty in Foxy recognized endoscopic training center. We welcome Bhavit sir. Our third chairperson is Dr. Sapan Doshi. Sapan sir is Secretary Himmatnagar Obs-Gynae Society and has more than 12 years of experience in the field of gynecology. Dr. Sapan specializes in the area of gynecology, obstetrics, infertility, laparoscopy, sonography to ensure the well-being of the mother and child. He has his own hospital, Tulip Hospital in Either. We welcome you, Sapan Doshi sir. I request Dr. Yamini Trivedi madam to introduce our speaker. I request Dr. Bhavit Shah sir to introduce the topic, and I request Dr. Sapan Doshi sir to conclude after that. Yamini madam, are you there?
Good evening. Good evening to organizing team and all learned faculties. I really feel privileged and honored to be part of this webinar session 132. Special thanks to Dr. MC Patel Saib, Dr. Suman, and all other organizing team. Introducing Dr. Mrugesh Patel. He is a gynec laparoscopic surgeon at Mehsana, and he has given a very short CV. He is the owner of Mother Care Hospital, Mehsana. We welcome you, Mrugesh sir. Such a wonderful topic and very interesting topic. Almost all might be doing this hysteroscopy and laparoscopy. Welcome you, sir.
Thank you, ma'am, for giving me a nice introduction. And first of all, I thanks to Dr. MC Patel sir and Dr. Yamini ma'am and Jyoti Banglo. I am taking a short lecture because I am not much in a favor of theoretical lecture, but MC Patel sir insists me, so I am taking this.
Sir, your 20,000 surgery record itself says you are believing in working only.
Yeah, thank you. I am just sharing my screen.
Yes, sir.
Screen is visualize that?
Yes, sir. Yes, sir.
Yes, thank you, ma'am.
Kindly do it full screen, sir.
Yes, yes. Just a minute, ma'am. Now it's okay, ma'am?
No, sir, not yet.
Yeah. Okay, I'm taking the lecture on the assessment of the infertility using the histoscopy and laparoscopy. First of all, I start my lecture that I don't believe you have to be better than everybody else. I believe you have to be better than you ever thought you could be. Right, ma'am. So infertility is such a sensitive issue. So we must be a good surgeon rather than a bad surgeon, because we have to give us some result to the patient. And patient came to you with the hopes and so much emotions. So you must be a very good surgeon. And the first surgery in the case of the infertility must be a final surgery. Right, ma'am? So little bit introduction regarding the infertility, that everybody knows that the failure of conceiving the pregnancy within 12 months of unprotected sexual intercourse, male and female are equally affected. Indian perspective in the point of the infertility is increased incidence in the countries with the higher infertility rate. In the developing countries, that the rate are 6.9 to 9.3%. And in the developed country, it is a 3.5 to 16.7. Infertility topics are like iceberg. It visualize more and disappear under the water. The causes of the infertility we have to divide it into tumor and the pelvic pathology 35%. Problems are 30%.
Excuse me, Mrugesh sir.
Yes, ma'am.
I think slides, do everybody see slides moving?
No,
I
sir.
think only the first slide is on the screen.
Yeah, and even it is not.
No, it is not full screen. So
Full
Murugesh,
screen.
make it
So
full screen first.
Yeah, full screen, and then slides are not.
It's a full screen, sir.
Oh, your first slide is seen only, and it's not moving also.
So
Yeah, my place is moving also.
It is not full screen.
मृगेश तू PowerPoint शो कर शो.
Okay, sir.
એકવાર એક્ઝિટ થઈને પાછા એન્ટ્રી કરવું
જો
પડે તો
નીચેના
જ આવશે.
બારમાં છેક નીચેના બારમાં છે.
એને એકવાર બહાર નીકળીને પાછા આવવું પડશે, નહીતર નહીં આવે.
કેમ એનું એક થાય?
ના, નહીં આવે, મને ખબર છે. He has to stop the sharing and then again share the presentation.
Murugesh.
Yes, sir.
જેમ નીતાબેને કહ્યું ને એ પ્રમાણે એક્ઝિટ થઈ જાય પહેલા તારું પ્રેઝન્ટેશન ખોલીને રાખ, પહેલી સ્લાઇડ છે ને એને મિનિમાઇઝ કરી દે અને પછી જોઈન કર.
એને નહીં નીકળી જવાનું, ખાલી શેરિંગ છે ને એ બંધ કરીને પાછું કરે.
એટલે સ્ક્રીન શેરિંગ બંધ કરશે તો જ એ થશે.
હા, એ
પહેલી સ્લાઇડ એને મિનિમાઇઝ કરી અને પછી જોઈન કરશે ને તો થશે.
આ છે ને અને રિકવરી મોડમાં છે, એટલે બાજુમાં દેખાય છે ને ઓલરેડી હી ઇઝ રિકવરિંગ ધ પ્રેઝન્ટેશન, એટલે બંધ જ કરીને રીસ્ટાર્ટ કર.
હા, એટલે એને ફૂલ સ્ક્રીન કર્યું નથી અથવા તો થયું નથી.
ના, આ રિકવરી મોડ છે, એમાંથી બહાર નીકળવું પડે.
ઓકે, ન્યુ શેર કરી સર.
ફરીથી આને બંધ કર.
પહેલા આને બંધ કરવું પડશે.
હા,
ઓકે, સ્ટોપ શેર. યસ.
હા,
ઓકે. Now it's visible, sir.
યસ, હવે PowerPoint શો ના, આ નહીં ચાલે. આમાં છે ને જો લેફ્ટ હેન્ડ સાઈડ માં છેક નીચે હશે, જો ક્લોઝ વાળું છે ને, લેફ્ટ હેન્ડ સાઈડ માં જે વ્હાઈટ બોક્સ છે ને એમાં છેક નીચે શું છે જો. હા, હા, હવે બરોબર છે. હવે સીધું શો કરી દે નીચેના બારમાં જઈ અને રાઈટ સાઈડ માં. હા, હા,
સ્લાઇડ શો પર જતા રહો તો થઈ જશે.
ફૂલ સ્ક્રીન કરો.
હા, બસ.
ઓકે, થેન્ક યુ.
ના, હજી નથી થયું.
ના, ફૂલ સ્ક્રીન નથી થયું.
ફૂલ સ્ક્રીન નહીં, શો કરો, શો.
શો જ કર્યું સર.
નથી થયું હજી.
ફૂલ સ્ક્રીન
તારું આખો સ્ક્રીન ભરાઈ જશે સ્લાઇડ થી.
તું ટાઈમ કેટલા વાગ્યાનો કર્યો? તું 7:30
પાવર પોઈન્ટ ઓપન કરી દીધું સર.
હવે ફરીથી શેર સ્ક્રીન કર.
શેર સ્ક્રીન કર્યું.
હવે એમાં જો છેક નીચેના બારમાં એક સ્ક્રીન જેવું દેખાય છે એને ક્લિક કર. હજી નીચે જતો અને રાઈટ સાઈડમાં જે 3 છે ને એમાં ત્રીજું કર. સ્લાઇડ શો બસ. હા બસ એ ક્લિક કર ક્લિક.
થેન્ક યુ સર.
ના ડબલ ક્લિક કર ત્યાં.
ડબલ ક્લિક
હજી થતું નથી શો. તો પછી તારે ઉપરના બારમાં જવું પડશે અને એમાં શો હશે. ફાઇલ વાળો જે બાર છે ને છેક ઉપર.
યસ સર એક સેકન્ડ.
હા
હા સ્લાઇડ શો.
યસ અને પછી શેર કર.
હવે ઝૂમમાં જઈને શેર કરું સર.
હા હવે પાછો શો કર. સ્લાઇડ શો. હા એને ક્લિક કર. શું વાત છે?
सर वो नीचे एक आइकॉन है ना, ये
નીચે આઇકોન he is clicking but it is not working it seems.
It's not working probably.
તો પછી શો થતું જ નહીં. આમાં જવા દે. આમાં હજી મોટી સ્ક્રીન
One by one slides કરવી પડશે.
પહેલેથી સ્લાઇડ શો કરીને શેર કરો.
ના પણ તો સ્લાઇડ શો કરશો ને તો એને ઝૂમ વાળું દેખાશે નહીં. આખું સ્ક્રીન ભરાઈ જશે સ્લાઇડ થી.
કંટ્રોલ ટેપ કરીને આવી જશે
સ્લાઇડ શો માં.
ઓકે કઈ નહીં આમાં જવા દે વાંધો નહીં.
सर इसमें भी दिख रहा है सर.
ચાલશે.
दिख रहा है पर कोई स्लाइड चेंज नहीं हो रही है मैम.
सर स्टार्ट
स्लाइड को चेंज करना पड़ेगा.
ऐसे भी दिख रहा है मैडम. सो यू कैन गो.
તારે સ્લાઇડ ચેન્જ કર્યા કરવી પડશે.
હા એ તો કર્યું પણ નથી તો.
आपको एक एक स्लाइड पे क्लिक करना पड़ेगा सर तो चेंज हो जाएगी. दिख रहा है इधर स्क्रीन पर दिख रहा है.
उसके पावर पॉइंट में कुछ प्रॉब्लम दिख रहा है.
મુકેશ એવું થઈ શકે કે તારું પ્રેઝન્ટેશન તું અમારી ટીમમાંથી કોઈને મોકલી દે અને એ લોકો રન કરે અને તું ડિસ્કસ કરી શકે.
કરું સર.
ના પણ સાહેબ એમાં વિડિયો હશે ને તો ટ્રાન્સફર કરવું બહુ મોટી ફાઇલ થઈ જશે.
હા એ વાત સાચી છે. ઓકે
હા આમ તો કરી દીધું છે સ્લાઇડ શો. તમને કેમ નથી દેખાતો ખ્યાલ નથી આવતો.
અચ્છા તારામાં ફૂલ સ્ક્રીન દેખાય છે?
હા મારામાં ફૂલ સ્ક્રીન દેખાય છે.
એટલે મેં કહ્યું ને કે આવું ત્યારે જ બને કે એના કોમ્પ્યુટરની કોમ્પિટિબિલિટીનો કોઈ ઇશ્યુ હશે. એને ટોટલ એક્ઝિટ થવું પડે. એનું પ્રેઝન્ટેશન બંધ કરી પછી ખોલે, પહેલી સ્લાઇડ ને મિનિમાઇઝ કરે ને પછી જોઈન કરે ને તો કદાચ પ્રોબ્લેમ સોલ્વ થશે.
અને ક્યારેક છે ને ભાવેનભાઈ
ત્યાં સુધી એવું કરાય કે
તમારી ટોક પતાવી દો.
હા બસ સુમન do one thing. Let Mrugesh be ready and meanwhile I can take over.
Okay sir. Okay.
Okay. Mrugesh.
હા સર.
ત્યાં સુધી હું છે ને મારું લેક્ચર લઈ લઉં છું.
So we move on to the third session.
ત્યાં સુધી તું તૈયાર થઈ જા મેં સમજાવ્યું એ પ્રમાણે.
બહુ તો એક લેપટોપ બદલી જો
અને સ્ટોપ શેરિંગ કરી દે પહેલા.
હા. Dr. Jyoti, Dr. Kalpana is not going to take over the third session.
Yes. I am taking. So Kalpana, Kalpana, please take session 3. Kalpana.
Third one.
Yes.
It's my pleasure to invite chairpersons for this wonderful talk on legal issues in high-risk pregnancy, which will be delivered by our program director, MC Patel sir, who is a medico-legal expert. I invite Dr. Dignesh sir.
Yes.
Who is a consultant OBS-GYN, Ashirwad Hospital, Palanpur. Welcome, sir, as a chairperson. And Dr. Mukesh Savalia, sir, who is the president-elect of Ahmedabad Uji Society, previously president of AVOGS also. Welcome, sir.
Welcome. Okay.
1 minute, sir. I'll just introduce the next chairperson also, and then I'll hand it over to you. It's my pleasure to welcome Mukund V. Patel, sir, who is a practicing gynecologist for the past 30 years, an assistant professor, GMER as Medical College, and also past vice president, IMA Gujarat. Welcome, sir. Over to you, chairpersons. Dr. Dignesh sir can invite our MC Patel sir. Mukesh sir can give an intro about the topic, and Mukund sir can give a concluding remarks after the talk.
Thank you, madam. At the outset, I would like to thank you, the organizers of Happy Learning Masterclass webinar series, for giving us the opportunity to chair this session. As such, Dr. MC Patel sir needs no introduction, but still I would like to complete the formalities. Sir is consultant obstetrician and gynecologist and medical legal counselor. He has served as vice president of FOXI in 2018. He has been the organizing secretary of AICOG in 2017. He was chairperson of Ethics and Medical Legal Committee FOXI 2011 to 2013. He was honorary secretary of state SOGO Gujarat. At present, he is honorary secretary. He is organizing chairperson of MMCon in 2018. He was honorary member of National Inspection and Monitoring Committee, PNDT Act, Government of India 2015. Honorary member of State Supervisory Board, PNDT Committee, Gujarat State from 2005 to 2009. He was president of Ahmedabad Obstetric and Gynec Society from 2010 and 2011. Honorary member of National Managing Body.
Dignesh, it will do.
Yeah. Okay, sir. And at last, I would like to say, if you want a peaceful life or peaceful night, then always keep the visiting card of Dr. MC Patel in your pocket.
Thank you, Dignesh. And
yes,
stop sharing screen so I can share my screen.
Yeah, sure.
So is it in full screen?
Yes.
So greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. High-risk pregnancy legal issues is today's topic for discussion. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank all the societies and president and secretary of respective societies who have joined this webinar: Ahmedabad, Gandhinagar, Mehsana, Palanpur, and Himmatnagar. Usually, I start any of my talk with this question: is it worth discussing? Yes, and if it is yes, then why? Because in our day-to-day obstetric practice, we take utmost care of any of our patients, but accident may happen at any time. And whenever there is an accident, it becomes a potential area as far as litigation is concerned. And as far as medical legal litigations are concerned, they are increasing in number constantly and steadily. And unluckily, we gynecologists rank first as far as litigation part is concerned. And our situation is like this in our obstetric practice. We have to save mother, we have to save baby, and at the same time, we have to save our own cap. And that is our obstetric practice. And let us see, these are real happened cases. In some cases in Gujarat, some outside Gujarat, and few of the cases, I was medical legal counselor in this cases. So it is real happened case in city of Ahmedabad only. Book patient, pregnancy after 15 years of active marriage life, conceived with ART treatment, regular antenatal checkup, USG every time, normal except polyhydramnios. Every time gynecologist friend from our Ahmedabad city only, she gave that report, everything is fine except mild polyhydramnios. At 36 weeks, in doing routine antenatal checkup, it was found to be a case of intrauterine fetal death, and cesarean section was advised. Routine pre-operative investigations were done, and blood sugar turned out to be 432, which was never done prior. This is the very important point to be mentioned, that prior there was no blood sugar done and it was case of GDM went undiagnosed, led to intrauterine fetal death. So case was filed. What happened thereafter, because that gynecologist and her husband didn't contact me. They had been once to me and then after they never turn up. So what happened with this case, I do not know exactly. But in this case, compensation was demanded 2 crores. So where thing went wrong? Can you relate to this type of situation in your day-to-day practice? Forgot blood grouping and later on find patient to be Rh negative. Forgot to do knuckle translucency, double and triple marker test, and many times baby had a Down syndrome. Forgot to GDM screening and patient found to be having a complication later. Forgot to ask for history of allergy and something goes wrong. Forgot this, forgot that, and so on. And these are some conditions we see in our day-to-day practice. Rh negative patient, you forgot antenatal NTD, low AFI and you took no action. Blood pressure 140 by 100 mm of Hg, urine albumin 1+ and no action taken. Pre-eclamptic patient complain of headache, you prescribe simply crocin and she threw a fit. Severe pre-eclamptic patient in labor, liver enzymes not done and HELP syndrome missed. Phone from patient on Sunday evening, reduced fetal movement. You said, show me tomorrow morning. And when patient had been to you, it was a case of intrauterine fetal death. And so on. These are certain conditions which we face in our day-to-day practice. So number one reason for litigation is dissatisfaction on part of patient and relative for forgetting to screen for high risk factor and neglecting a symptom or positive report as far as screening part is concerned. So many times questions come in this type of situation, whether it is considered error of judgment or it is negligence on part of treating doctor. So how to tackle our Alzheimer, not to lose any important point. So pregnancy profile to be handed over at first visit. This is practice of few of our friends, so I mentioned. Pregnancy profile is handed over to the patient at first visit. Get it signed on second visit with clarification. So in that pregnancy profile, everything is mentioned about pregnancy, probable complication, all the investigation advice, at what gestational stage, which kind of investigation should be done. And one more carry-home message, follow guideline for screening and ensure that you will not miss any high-risk factor. So with this case, these are the carry-home message. Let us see one more important case. It was decided in court, fever between 30 to 34 weeks of pregnancy, torch was not done, IUGR baby delivered prematurely at 36 weeks. Later on, she developed cerebral palsy. Inference held in the court was there was no negligence on part of treating doctor. Torch is not routine screening test as per Foxy guideline, because during the fighting this case, Foxy guideline was taken into consideration and court has also taken the base that under Foxy guideline, torch is not routine screening test. It is also indicated for fever in first trimester and cerebral palsy cannot be diagnosed antenatally. So these were the inference held by the court, and this case was decided in favor of doctor merely on ground that doctor has followed the treatment as per standard guideline of Foxy. So follow guideline and protocol for screening or management of patient, particularly when you are dealing with the high-risk pregnancy cases like GDM, Rh negative, twins, severe PI, preeclampsia, and in case of crash LSCS. So let us see one more case. This is also real happened case. It was unbooked patient, primary 34 weeks of pregnancy with PIH. Actually, this patient was taken care by gynecologist at Himmatnagar. This is real happened case. And yes, and customary tradition, patient had been to Kadi at her maternal place for delivery. She was primary, and at 34 weeks of pregnancy, this was very first visit of gynecologist of Kadi, and she was a case of PIH. Advised necessary investigation and treatment, but unlucky on part of patient as well as that gynecologist from Kadi, she developed abruptio placentae and intrauterine fetal death. Cesarean section was advised, but relative opted option to go for second opinion in nearby town. So patient was brought from Kadi to Kalol and they went to surgeon and not to gynecologist in Kalol. And in during this surgery, gynecologist was assisting, but cesarean section was performed by general surgeon. Again, unlucky on part of patient as well as that surgeon also. During cesarean section, she developed atonic PPH and hysterectomy was done. I was defending both of them, gynecologist from Kadi and surgeon from Kalol. We won the case. Ultimately, in court of law, we could prove that atonic PPH is a known complication of patient, and whatever one responsible gynecologist can do was done by that surgeon and gynecologist who was assisting. And hysterectomy was life-saving in this condition because doctor had given blood transfusion, hot mop, then stepwise devascularization. But in spite of all these efforts, oxytocin, methergine, etc., bleeding was not getting control, and ultimately hysterectomy was the only life-saving measures. So we could convince in court of law, and case was decided in favor of doctor. But in this type of situation, we should be very much updated with our record to prove in court of law. So in this particular case, allegation to first gynecologist from Kadi was not properly managed to prevent abruptio placentae, and allegation to surgeon was not tried to prevent PPH, and atonic PPH was not managed properly. But in court of law, we could manage to explain and convince court that atonic PPH was managed very properly, and atonic PPH was managed properly, and hysterectomy was the life-saving in this condition. Let us see one more important case. This is real happened case in city of Ahmedabad only. It was case of lower segment cesarean section, and during cesarean section there was bilateral uterine artery tear. As such, this patient had been to our gynecologist. Gynecologist advised elective cesarean section as patient was RH negative, but patient didn't give consent. Patient left hospital, and after 3 days at 11 p.m. patient had been in emergency, and as she was RH negative, it was very difficult for gynecologists to manage blood at night, and during cesarean section this happened, bilateral uterine artery tear. Patient was RH negative, blood was not ready, cross match was not done. During shifting patient to municipal medical hospital, that is NHL medical hospital, patient expired on the way, notice was served, case was filed, and allegation was not anticipated complication procedure or intensive care, and inference held by the court. Post-mortem examination showed that it was intra-abdominal hemorrhage following negligent surgical procedure, no blood kept ready, medical record not to be believed. Actually, what happened in operative note, gynecologist mentioned that vitals were within normal limit, and note of anesthesiologist, in that note, anesthesiologist wrote that vitals were compromised. So there was contradiction in note of gynecologist and anesthesiologist. So court didn't consider record to be believed. So compensation of rupees 2.35 lakhs was awarded in favor of relative of patient. This case was decided in 1997, and at that time amount of 2.35 lakhs was big amount. So number two reason for litigation is not cross-matching blood during high-risk delivery. So carry-home message in this type of case is cross-match, especially in RH negative patient, and consent for blood transfusion should be taken separately. Proper record keeping. There should not be contradiction with all the doctors who have involved in the treatment, and as far as note of all the doctors are concerned. Let us see one more important case. It was also case of RH negative and indirect Coombs test, and NTD was given at 32 weeks of pregnancy. Again, in this case also patient developed atonic PPH during cesarean section. Subtotal hysterectomy was done, but ultimately patient was shifted to tertiary care hospital, and patient expired during the course of treatment. So this case was decided in National Commission, and inference was on part of National Commission was there was no negligence in management blood, but blood should have been arranged or patient should have been referred to higher center. So whenever you are facing a case of RH negative, naturally you should anticipate this type of problem, and at least cross match should be sent. And this is our observation from our medical legal practice. 80% medical legal cases against gynecologists are related to obstetric, and out of those, 80% are related to cesarean section complication. And out of those complications, 80% are related to hemorrhage. So it is very clear that if one wants to be 80% free of litigation, take care of bleeding, that is hemorrhage, and cross-match blood. Not cross-matching blood during high-risk pregnancy is one more reason for litigation. Few of our friends have a habit to send blood sample in each and every patient when patient is getting admitted for labor in nearby blood bank, and they demand blood if at all it is required. So it is good habit, but is it possible in each and every patient? If you can do, it shows your the consent to save life of patient, and it becomes a good defense if at all you are facing litigation. So let us say few are the situation, and in this type of situation, you advise your patient, but many a times patient may go hostile in court of law. No intercourse for placenta previa patient, but patient will say in court of law, you never told, you never advised. Counsel patient for IUGR patient about its risk, you never told. You had told that diabetic mellitus, sudden IUFD is possible, but patient will go hostile in court of law, you never told. You said that everything is okay. Husband says now suddenly how come she died of amniotic fluid embolism? So these are some special conditions or high risk condition. In this type of situation, we are facing litigation in this type of situation. So lack of counseling and proper consent is one more reason for litigation. So it is not just enough to communicate, but you should able to prove in court of law that you did it. So it is very important thing. Let us say one more interesting case. Again, it was case of pregnancy with mitral stenosis and mitral incompetence, seen by physician. Cardiologist was not involved. MTP was not advised. At 8 months of pregnancy, patient went into failure. Physician advised lower segment cesarean section. Post-operative death in ICU within 4 hours of treatment. So during deciding this case at National Commission at Delhi, inference held by the commission was cardiologist was not involved, and letterhead saying physician and cardiologist, that is letterhead of physician, is misrepresentation. MTP was not advised, no surgical intervention was advised during second trimester, and epidural anesthesia or spinal anesthesia should have been preferred in case of CCF. So in this case, compensation of rupees 7.8 lakhs was awarded in favor of relative of patient. And one stricture was passed by National Commission. Many laboratories and radiological units are run by unqualified doctors. Let us see one more case. In this case, antenatal record of visits in 9 months shows that tachycardia and breathlessness, no physician reference. Patient died 4 days after delivery due to cardiomyopathy. Let us see one more case. Antenatal visits uneventful, cesarean section uneventful. On 8th post-operative day, patient was in ICU and diagnosed as a tight mitral stenosis. So I am the only consultant approach is dangerous one, and is one more reason for litigation. So with this type of cases, carry home message, make a habit to evaluate respiratory and cardiovascular system, because so many of friends have no habit to put stethoscope on chest of patient. Take reference of super specialty cardiologists also as early as possible whenever you are facing this type of cases, and multi-speciality approach is always advisable in this type of cases, because it shows your consent to take utmost care of your patient and to save life of patient. One more question, where should this type of patient of high risk pregnancy should be managed? As such, there is no guideline at present, but during facing this type of cases in court of law, court do try to get information about your infrastructure where you have managed the patient. So naturally on part of court, they will ask, and they will ask that ask yourself at your center, are you able to arrange blood, arrange any consultant, facility for emergency investigation, facility for crash LSCS, backup of neonatal care, multi-speciality approach. If you can manage case in this way, that any place you can manage any case of high-risk pregnancy, but in court of law, whenever you are facing litigation, you should be in a position to prove that you have all this facility to manage this type of cases. Let us see one more case. This is very real happen case in city of Ghaziabad. Our own gynecologist, patient was admitted with labor pain. She was in good health at time of admission. No satisfactory progress. Cesarean section was advised, but patient and relative were reluctant to go for consent, and doctor insisted that there is no way to go for cesarean unless to go for cesarean section, and ultimately consent was given. Cesarean section was done, but after delivery, patient suddenly developed cardiorespiratory arrest. Amniotic fluid embolism was suspected. Patient was intubated, immediately started positive pressure respiration, and patient showed signs of partial revival. Cesarean section was completed very quickly. Relatives were informed about the sudden happening of serious condition, and thereafter patient was shifted in ambulance in nearby tertiary care center and with escort with positive pressure respiration by gynecologist herself. In ambulance, doctor accompanying the patient. Patient was put on ventilator support where patient was referred. Patient responded, but ultimately patient developed cerebral hypoxia and patient went into vegetative form, and ultimately patient expired during course of treatment. So case was filed before UP Medical Council and UP State Commission, and compensation was demanded 1990 lakhs. So allegation was assured normal delivery, treated patient casually and didn't advise required investigation as per standard norm. During labor, one injection was administered which stopped pain for some time and then created situation such that complainant was compelled to give consent for lower segment seizures. These are common allegations in this type of situation. So point in issue in this case was whether there was any negligence or any deficiency in service while managing patient and performing lower segment cesarean section. So Uttar Pradesh Medical Council has an inference that Medical Council did not hold a doctor responsible for this negligence at the time of performing cesarean section and leading to amniotic fluid embolism. But ethical committee was of opinion that doctors should be restricted to operate in such condition, which seems to be not up to mark. And Chief Medical Officer Ghaziabad should be informed that doctor will not operate in this hospital unless facilities are improved. And State Commission verdict was that doctors should be considered responsible and awarded compensation to the complainant. Appeal was held in National Commission, and then two of our medical legal counselor were at rescue of our gynecologist from Ghaziabad. And observation and inference on part of court was, in order to succeed claim of medical negligence case, three requirements need to be met. One, accidental nature of misconduct on part of doctor. Second, existence of proven damage. And third, it should be direct relationship of doctor's actions and damage done to patient. Doctors shall put in a place all necessary measures as to current scientific knowledge. So with this inference, this case was decided. And this was also taken into consideration that court was in the position that we note that doctor performed her duty with miserable standard and as per accepted practice, and patient was appropriately referred to higher center well in time. And in this particular case in National Commission, we put references of standard textbook of Williams, and as far as amniotic fluid embolism, we convinced the National Commission that amniotic fluid embolism, it is a rare but often fatal complication of pregnancy. Onset can neither be predicted nor be prevented. Infrequent, unpredictable catastrophic complication causing cardiorespiratory collapse, virtually impossible to predict which patients are at risk. Diagnosis must be based on spectrum of clinical signs and symptoms by exclusion of other causes. And amniotic fluid embolism is a syndrome typically occurs during labor, soon after vaginal or cesarean delivery, or during second trimester dilatation and evacuation procedure. So it is virtually impossible to predict which patients are at risk of amniotic fluid embolism. So with reference of Williams standard textbook, we could convince National Commission. And one more inference was given from Williams standard textbook. Most cases of amniotic fluid are associated with dismal maternal and fetal outcome, regardless of quality of care. So in spite of all care on caution and treatment taken, guarantee cannot be given was considered by National Commission. Early recognition of amniotic fluid embolism with prompt intervention is paramount for successful outcome. Management is resuscitative, maintaining vital signs, and treating hemodynamic and coagulopathy derangement as they occur. And a team approach among obstetricians, anesthesiologists, and intensivists is necessary as far as treatment outcome is concerned. And despite early intervention, maternal and fetal mortality remains high. So this reference was taken from Williams. And further, it was added from Williams' textbook that long-term consequences will depend on severity of cerebral anoxia and on how much irreversible damage has occurred in the brain. So with these references, we could convince court, and one more, this reference was also taken into consideration. And we could quote one case which was decided in apex court, that is Supreme Court. And in this particular case, skill of medical practitioner differs from doctor to doctor, and very nature of profession is such there may be more than one course of treatment which may be advisable for treating a patient, and courts would indeed be slow in attributing negligence on part of doctor if he has performed his duty to the best of his ability with due care and caution. And in the same case, Supreme Court has this inference also. Medical opinion may differ with regard to course of action to be taken by doctor treating a patient, but as long as doctor acts in a manner which is acceptable to medical profession and court finds that he has attended on patient with due care, skill and diligence, and if patient still doesn't survive or suffers permanent ailments, it would be difficult to hold doctor to be guilty of negligence. So court was very clear in that very case. Supreme Court has very specifically mentioned that irrespective of ultimate outcome of the treatment given, if doctor has taken utmost care of patient as standard medical norms, then he could be out of problem of negligence. And one more case, Supreme Court has mentioned that Consumer Protection Act should not be a halter around the neck of doctor to make them fearful and apprehensive of taking professional decision at crucial moment to explore possibility of reviving patient hanging between life and death. Doctor in complicated cases have to take decision or have to take chance, even if there is a rate of survival is very low, and doctor faced with emergency ordinarily tries his level best to redeem the patient out of his suffering. And in this particular case, doctor was qualified as an obstetrician and experienced one. Cesarean section was performed as per standard procedure, but unfortunately, patient suffered cardiac arrest due to unpredictable amniotic fluid embolism. And though immediately resuscitative steps were performed by doctor, but patient suffered cerebral hypoxia. It was not due to negligence or deficiency while conducting cesarean section or management of amniotic fluid embolism, and state commissioner has erred in law to hold it as a medical negligence. So in this instant case was decided in favor of our gynecologist from Ghaziabad, and thank goes to two medical legal counselor. They appeared in state commission in favor of our doctor friends, and this judgment has become landmark judgment as far as case of amniotic fluid embolism is concerned. Let us say one more issue. Terminally ill patient, when patient is on ventilator, many times relative will say we cannot afford any more, and intensivists say it is a hopeless case now onward. So in this type of situation, we have a very tricky situation to face. So do not write, do not resuscitate, because passive euthanasia is not allowed in India. And Supreme Court has a judgment in only one case of Aruna Sanbag case. It was a very special case. In this very case, passive euthanasia was allowed by Supreme Court. But now passive euthanasia is not allowed in other cases. So we should be very clear at the time of taking this type of decision. Transfer of patient is one more area. So patient or patient party will decide where patient wants to go. So government hospital, trust hospital, private hospital, medical college hospital. And when you give all the transfer document, take a signature of patient if possible, or husband or relative, and date and time. It is very much important where you transfer patient to higher center. Confirm availability of bed, operation theater, instrument like ventilator with right and proper person where you are referring the patient. Because many a times when patient reaches their hospital, ventilator is not available and patient will have to shift it to another hospital and precious time is wasted. So before you ship patient to any other center, please confirm with all this facility. Escort of patient, naturally a responsible doctor should escort patient in the same ambulance. And if patient doctor is busy with another emergency, then equally qualified person can escort the patient, and anesthesiologist is the best person in this type of situation. You can use pneumatic anti-shock garment also in case of shock, because it saves your time, and many times it becomes a rescue as far as saving of life of patient is concerned. Handing over patient to proper person where you have referred the patient, and acknowledgement on your paper with date and time, and transfer document. All the document you have to give to the patient party at the time of transferring the patient. So you have not to remember everything, because it is a paucity of time. I am not discussing all this, but I would like to refer only one thing. You have to simply visit Foxy website, and Foxy uniform consent are available on Foxy website with 3 medical legal counselor, Dr. Dilip Walke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. MC Patel from Ahmedabad. We have prepared almost 30 different consent. Say, for example, cesarean section, hysterectomy, abdominal, vaginal, endoscopy, termination of pregnancy, medical, surgical method, referring patient to higher center in critically ill patient, consent for anesthesia, consent for blood transfusion. So there are 30 consents available on Foxy website. You can simply download and utilize in your day-to-day practice. One more interesting story, and I will conclude my talk. Story of young junior who had just started practice. Post cesarean section, sudden breathlessness. It was query amniotic fluid embolism. Shifted to tertiary care hospital. Died after 4 hours of treatment. Now relative made a police case and threatened that our junior doctor that they will put a case in a consumer forum for 1 crore. Now question to our young junior gynecologist: if case goes against me and court awards 1 crore, from where will I recover the amount? So indemnity is the answer in our day-to-day practice in era of CPA. So should we take indemnity cover? Of course, yes, but it should be adequate one. So how type of practice you are dealing with, as per your practice, you should have an adequate cover as far as indemnity is concerned. So what to do, how to prevent all this situation? Because every high-risk pregnancy are potential threat as far as litigations are concerned, and you may end up into litigation with this type of common allegation: delayed in diagnosis, investigation or treatment, misdiagnosis, investigation or treatment, wrong diagnosis, unnecessary investigation, no proper consent, staff not qualified, infrastructure issues, emergency services not rendered properly, communication failure, delayed in transfer, complications, morbidity, whether maternal and or fetal, mortality, whether maternal or fetal, overcharging, tremendous expense against unexpected result could be one more allegation. So look like avoiding medical legal problem in our practice is a difficult balancing act. No, not at all. Then what to do and how to prevent? Practice foreseeability, that is anticipation, good communication, valid consent and proper documentation, and you will be simply sail through. So court and law expect from us to anticipate certain complication, and we should be readily available to deal with the situation. Say, for example, if you are dealing with a case of history of two previous LSCS, and this time if it is a case of central placenta previa, naturally one should anticipate that patient may end up into PPH. Patient may need even obstetric hysterectomy also, and you should be readily available to deal with situation. And in this type of situation, proper counseling is very much important. And usually we start like this: what is the complaint? And there are so many questions on part of patient. Why did it happen? How it can be avoided? Will it happen again? Could it have been avoided? So at the time of counseling, we are under obligation to explain everything about all the alternative modalities of treatment, possibility of morbidity, probable expense, possibility of mortality in severe condition, probable prognosis, probable complications, possibility of blood transfusion, risk involved, outcome of baby, need of NICU backup. But whatever you explain, it should be in a very simple language, no much medical jargon, and no rosy picture, no tall claim about result. This not should be the approach, because in our obstetric practice, we consider our result like Aishwarya Rai, but it may turn like this at any time. And in eye of law, when you claim to be master, you are supposed to be master. So proper communication, proper documentation, and when you take signature on your consent paper, it becomes a documentation of your communication. And when you offer all those record in court of law, it becomes a communication of your documentation. So records are always at your rescue. So keep them up to date. What was done? Nothing was neglected. Given treatment fully met with standard demanded by law and ethics, and it should be easily acceptable whenever offered by the court. Doctor is bound to produce record whenever asked by the court, and if it doesn't, then adverse inference might be drawn. And it is very obvious: good record is good defense, poor record is poor defense, and no record is no defense. And it has been my experience during my medical legal practice, we doctors' friends are very poor as far as record keeping is concerned. There is always a way. So to conclude, pregnancy profile, protocols and checklists we have to strictly follow, proper counseling and proper consent, proper documentation, multi-speciality approach, no compromise on statutory requirements, professional indemnity, be vigilant in your practice, otherwise be ready to face this type of situation in court of law, comply with the provisions of law, formation of local level RUST team or medical legal cell, because in any given situation, member of RUST team can be at your help for surgical assistance at the time of breaking bad news, or at the time of mob violence, or at the time of facing litigation. So member of RUST team could be helpful in day-to-day practice. Take medical legal advice from point one, if at all it is required, because this gentleman has so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. So have some basic legal knowledge. Always obtain medical legal advice whenever you are in doubt. So God bless you. Have a litigation-free medical practice, because in spite of all these professional and occupational hazards, our journey to serve human and mankind is always on and on. And if you want to sleep like this, take tender care of your patient. Pray Almighty God before going to sleep, and keep my visiting card below your pillow, because सत्य परेशान हो सकता है लेकिन पराजित नहीं. And this is last slide. This is law of leopard behind innocent gynecologist, and see the role of medical legal counselor, how he can be useful in any given situation. So please do not hesitate to have a phone call to medical legal advisor whenever you are in doubt. So thank you. With regards, salute to all the societies who have joined this webinar. Thank you very much. Please do not assume. Please ask if any query or any question, if time and chairpersons permit. Thank you very much.
Thank you, sir. Can I request Dr. Mukund Patel to conclude this? Dr. Mukund Patel.
Thank you. Yes, madam. Thank you, Dr. MC Patel, sir, for providing a good talk on preventing medical legal aspect during high-risk pregnancy. Sir is ready to help every gynecologist in difficult situation of medical litigation. Thank you, Dr. MC Patel, sir, for providing good information and good talks regarding medical legal issue. Thank you. And I conclude the session and switching the session to the MOC.
Thank you.
Thank you. Sir, right now there are no questions, sir.
Okay, no issue.
Can I ask one question?
Yes.
Dr. MC Patel, does adequate indemnity cover gives you a protection against civil and criminal cases both?
So it depends upon the company prospects. Because in few of the company, they will entertain only civil or CPA litigation, and criminal litigation, they will not entertain. But as far as criminal part is concerned, it becomes a personal allegation, and in this criminal litigation, few of the companies, say for example, indemnity for Foxy, they will entertain, they will give you legal assistance. But if at all you lose, and if there is imprisonment, then naturally you have to face by yourself only. But if at all any compensation is awarded, then that part is taken care by professional indemnity on part of Foxy.
Good enough. Thank you.
Yes, Jyoti.
Yes, sir. Sir, shall we move to the panel discussion, sir?
If Dr. Mrugesh is ready with
yeah, we have the second session still to be done.
Yes, Dr. Mukesh, sir. Sir, can we play the?
Is he ready, Mrugesh? Mrugesh, are you ready? Or should we proceed with panel?
Dr. Mukesh is operating the that
okay, no issue. Then we straightway we proceed to panel, and if at all Mukesh is available after panel, we will
after the panel, Mukesh will join.
Yes, no issue.
So
yes.
I invite Dr. Kalpana, madam, for this introduction of this panel. Kalpana.
Yeah, shall we have the profile of our moderators? Yeah, we have very learned moderators, Parul Kotwada, who is actually, sir is chairperson-elect IPC and past vice president of the past chairperson, Adolescent Health Committee for the and past president of SOGOG, also past president Ahmedabad OG Society. Actually, we have enjoyed your expert views in Tamil Nadu annual conference. You visited Chennai. We enjoyed your expert views, sir. Welcome once again for this wonderful panel discussion as a moderator, sir.
Thank you.
Our next co-moderator is Manoj Pandya, sir, who is a director, Kadam Women's Hospital, Ahmedabad. Sir is practicing infertility, high-risk pregnancy, and also fetal medicine for the past 32 years with huge experience. His hospital received Best Nursing Home Award in 2007 from Chief Minister of Gujarat and our Honorable Prime Minister, Shri Narendra Modi ji. Welcome, sir.
Thank you very much.
And we have experts and panelists for this panel discussion. It's my pleasure to invite our experts, Dr. Bharti Rajshekar, who is President-elect Kasoga, and also she has been very active in Kasoga and as a honorary secretary 21 to 23. She's into Indian Red Cross, KPMA state vice president also. She's into various organizations, including IMA, but she past vice president IMA and also past president Hazan OG Society.
Madam, you can skip it and make it short, madam. It's okay.
Bharti, call me Dr. Kalpana.
Oh, Kalpana, I just skip it.
Yes, you don't recognize me. Okay. And she has received various awards, including Public Awareness Committee. She was a zonal coordinator, and also in Oncology Committee, Medical Ethics Committee, and so much of experience in various committees. She has received various awards, President Medal from top of Final MBBS, and FOGC President Rotating Trophy during her secretary period, DK Tank Awards twice as HSOG Secretary, President, and faculty in various conferences. Welcome Dr. Bharati as an expert. We are eagerly waiting for your expert comments, which would be
Thank
really
you,
useful
Kalpana.
for the. And our next expert is none other than our Rekha Rajendra Kumar, who is also very dynamic and active in Kasoga. She is the Vice President of Bangalore Ruchi Society, and she has been awarded various awards, and she got first rank in MD and during MBBS examination also. She was too good, topper in those examinations, and she's a South Zone Coordinator for the Infertility Committee, Chairperson Infertility ART Committee Kasoga 2022, and she's a peer reviewer, Jogi. She has got a teaching experience of various years, and EC member of various organizations, and she's published many papers in various national and international conferences and journals. Welcome, Dr. Rekha. To hear you as an expert, it's our pleasure.
Thank you.
Our panelists are Corona. Yeah, we have a wonderful panelist, Dr. Anand Chaudhary, sir, past president, Palanpur Uji Society, Dr. Rohan Patel, sir, Dr. Anand Chaudhary, sir, is a director. Did we have the slides? Yes. Upon IVF Center, sir is into private practice for the past 14 years, ART consultant and endoscopist too. IVF Center at Palanpur for the past 6 years and doing conventional IVF. Past president of Palanpur Uji Society, awarded Best Society runner-up during his presidential years. Recently launched labor suit also. Sir has been trained in sonography, and even in embryology and ICSI from ART, published papers in various journals. Welcome, sir, as a panelist.
Thank you.
Our next panelist is Dr. Rohan Patel, sir, from Vardhan Women Hospital, Vara's IVF Center. Sir has done diploma and fellowship in minimal access surgery, ultrasound training from FOGC, and also diploma in gynecological endoscopy from Germany. Sir is a joint organizing secretary, GIMA CON, conducted in 2017. Sir's interest is laparoscopy and infertility. Welcome, sir. Our next panelist is Dr. Ratnesh Patel, sir, consultant gynecologist, Gayatri Hospital, Gandhinagar. Welcome, sir. I invite the next panelist, Dr. Viral Luha, sir, who has worked as a gynecologist superintendent at MB Patel Hospital, Gandhinagar, and also had started his own private nursing home, Sharda Bhakti Hospital, Gandhinagar, and almost for decades it's running successfully. Worked with MD India Healthcare into various tied up various insurance companies for his hospital. Welcome, sir.
Okay.
Our next panelist, Dr. Nitha Thackeray, Honorary Secretary of AOGS, had actually one webinar for our FOGSI Infertility Committee with Nitha Thackeray ma'am also. Madam is Honorary Joint Secretary AOGS 21 to 22. West Zone Coordinator, Team FOGSI 2020, FOGSI Eurogynac Committee Chairperson 17 to 19, past assistant professor of various medical colleges. Madam's interest is urogynecology, high-risk pregnancy, gynec endoscopy, Director, Wellcare Hospital, Ahmedabad, Senior Consultant, KD Hospital, and also was a health column writer for the Times of India. Welcome, ma'am. Our next panelist is Dr. Gunjan Badrakia, who is a gold medalist, fetal medicine expert, and consultant in Sharada Women's Hospital, Gandhinagar. Sir has completed fellowship in fetal cardiology from Spain, certified NT scanner from FMF UK, and Sir is an assistant professor, Bhavnagar Medical College, chief at Sharada Women's Hospital, Gandhinagar. Welcome, sir. Our next panelist is Kaushik Vyas, who is a consultant at Karla Hospital, Ahmedabad. Areas of interest is emergency obstetrics. Welcome, sir. Dr. Naresh Prajpati, who is a president, Palanpur Uji Society, past secretary of Palanpur Uji Society, and also with the vast experience of almost years as an obstetrician and gynecologist. Welcome, sir.
Thank you, madam.
I invite Dr. Akshay C. Shah, who is an associate professor of Gyne Department, SVP Hospital, NHL Municipal Medical College, Ahmedabad. Sir's interest is high-risk pregnancy. Welcome, sir.
Madam.
Our next panelist is Dr. Shashwat, who is the consultant assistant professor, NHL Municipal Medical College, Ahmedabad, clinical secretary, AOGS, chief coordinator, West Zone Perinatology Committee, FOGSI, master trainer of FOGSI John Hopkins Hospital, Safe Motherhood Initiative, published 18 articles, invited faculty in many national and international conferences. His interest is infertility, endoscopy, and high-risk pregnancy. Welcome, sir. Over to you, moderators, waiting for an interesting panel discussion with interesting cases.
Can you allow Dr. Manoj Pandya to share screen?
Yeah, he can do that. So.
Okay.
Manoj is sharing his screen.
Yes.
Allow me, on behalf of both of us, to thank and compliment Dr. MC Patel. Since more than a year, he has been continuously devoting time and effort for this academic activity. And he's going to go on. Generally, he does it on all Tuesdays, but this time he has added Thursday as well. Let me be frank with you. The entire slides and presentations are prepared by my colleague, Dr. Manoj. And
thanks, Parvali, for giving that credit and allowing me to do it independently. Thank you very much.
And as already a lot of time has been used up, we have restricted. We anticipated this may happen, so we have just 3 cases, but very important cases to discuss. And since the panel is huge, 10 people, everyone might get maybe 3 or 4 minutes per person, because few minutes we may also use up, me and Manoj. Manoj, please start off.
Can you see my screen? Slides are also moving?
Yes.
Okay. So before we start our discussions on the crisis in labor room, and thanking all the organizers, all the persons involved in this webinar, there are the simple rules for the panel discussion. I think there were 10 panelists. I don't know how many of them are present, but so no ill feelings to all the esteemed panelists. We will go in the chronological order as the name appears, just like the name appears in the movie after movie is over. So we will start with the Dr. Akshay, Dr. Anand, Gunjan, Kaushik, Naresh, Neetaben, Ratnesh, Rohan, Shashwat, and Viral in this order. If any of the panelists is not present, the questions can be jumped over to the next panelist. And I feel that expert comment, Dr. Bharti and Dr. Rekha, they can intervene at any point of time if there is anything to be added as an expert comment. So, friends, as we all have experience in our labor practice of many years, there is considerable difference between the critical patient admitted in labor room with difficulty and crisis or trouble shooting up suddenly in the labor room, where our obstetrician and labor room staffs, they are unprepared if trouble is not anticipated. As Dr. MC Patel rightly insisted in many times in his lecture, that anticipation will save you from all the troubles. And usually they are caught unaware. So coming with the first case, a 28-year-old G3P2 L2 39 weeks in labor room. She had a vaginal delivery with episiotomy, female child of 2.9 kg. The placenta delivered in 15 minutes with active management of third stage of labor. But after 1 hour, there was a clot, huge clot with the bleeding privy. She complained of abdominal pain, weakness, dizziness. On examination, patient was pale, cold, and clammy. The pulse was 128 beat per minute, BP was 70/54, respiration rate was 22 minutes, and SpO2 was 91%. During the per abdomen examination, the uterus was just above the umbilicus, but it was very soft, doughy feel with mild tenderness. And on PV examination, there was large clot in the vagina with no bleeding, particularly from the episiotomy side. So, Dr. Akshay, I would like to ask your opinion. With such clinical signs and symptoms, what is the severity of this stage, and would you like to have a bedside assessment with shock index? Dr. Akshay.
Yes, sir. Can I have the previous? Yes, sir. Can I have the previous slide, please?
Yeah. Yes. This one?
Yes, sir. It is visible.
Okay.
So no blood investigations had been received, right? It must have been sent, but not received yet.
And yeah, you have to manage. Rather, this was the case. Crisis occurred. So
yes, sir.
What really the first thing? Rather.
So, sir, the vitals itself are suggestive that 128 pulse and blood pressure 70 systolic. It is definitely a severe postpartum hemorrhage, and it is a severe shock. Obviously, so hemodynamic management comes first, and as soon as possible, we need to have ready with blood transfusion.
Management will come later on. Just I am asking you about these two things. Which stage of severity, and would you like to have a modified shock index determination with the patient immediately?
Yes, sir, 100%. So we have this charts with us, and that can definitely let us know that it is a severe shock. So we need to manage accordingly, sir.
Thank you, Akshay. Now the next question is to Dr. Anand. As you all know, as we know, that there are 4 components important which are to be done simultaneously when there is a crisis. Can you just enumerate the 4 components?
The first thing is we have to make a team and we have to start our resuscitation efforts. So we have to call our anesthetist for a help.
You need to highlight about the communication with whom.
Yes, first of all, we will communicate with all the expert staff. We call them inside for helping. We will ask our anesthetist to come, and we will ask our senior gynecologist to be with us in whole of the management. So these all are the team, and we should manage for the blood, and we should call the blood bank for the blood transfusion. And other than that, we should start resuscitation with
Resuscitation part
hypovolemic
will be
shock.
later on. First, I want to highlight upon the communication, because the crisis which has happened suddenly. So when you are managing, these are the 4 persons where you will like to communicate properly and adequately, so that there is no confusion and messages are conveyed very loud and clear to entire team. Very important to communicate with the patient if she is conscious or with her relative or partner. Now, Dr. Gunjan, can we come to the next? I think Gunjan is there. No, Dr. Kaushik is Dr. Kaushik.
He's there. Kaushik is there.
Kaushik, why?
Yes. Yes.
Yeah. That,
Yeah.
Being in a very expert in emergency obstetric medicine, just let us know what is the second component, that is resuscitation. How would you resuscitate this patient after communication has
resuscitation?
Yeah.
First of all, at least 2 wide-bore cannulas have to be taken. ABC of resuscitation, airway, breathing, and circulation is to be maintained. Here, as per your first slide, it is a definite case of atonic PPH with blood clot. So the cause is already there, and we should remove the clot. We should try to contract the uterus with the help of the egg bolix. That
will come on later, but in resuscitation, at least oxygen has to be started. We have to restore the circulating.
Crystalloid solution, RL, Ringer's lactate is to be started very fast with the wide-bore cannula.
And when you are taking when you are securing 2 veins with the wide-bore needle, which are the investigations would you like to take at the same time?
Yeah, immediately we should withdraw the blood sample for cross-match, as well as for the investigations, complete blood count, coagulation profile, the baseline, and for cross-match.
Correct. Very nice. Now again, the same question lies with you only, that we have taken the 2 wide-bore needles, collected the blood for the investigations. Now, as far as the transfusion is concerned, till blood is awaited, what will you transfuse?
Yeah, crystalloid in the form of Ringer's lactate, Hartmann solution is the first choice. And then on the other side, we can start with the colloids till the bloods are coming.
Correct. And if cross-match is not being done, would you like to give blood bank any specific instruction for the immediate blood supply?
Blood type can be done, or RH O negative type blood can be given.
Correct. And little bit think about the components.
Yeah.
Can you elaborate about the components?
Yes, fresh frozen plasma is to be, it can be started without even doing cross-match and typing. Fresh frozen plasma.
Okay.
And platelets after the investigations, if you find the platelets very less, actually less than 20,000,
just enumerate the figure. At what figure will you like to go your platelets?
Platelets, if with active bleeding, it is less than 40,000, and if there is no bleeding, till 20,000 we can wait.
Okay. Right.
Here, I would like to add only one thing, that there is no need of doing any massive infusion. The overload also is to be prevented. So just make sure that you are giving crystalloid, but it's not required to be in a massive form, depending on what is the loss. So we have to monitor.
Actually, the shock index, which is shown already, 128 pulse and 70 systolic blood pressure, it itself shows that it is a severe case of hemorrhage. So initially, for the till the investigations will come, and till the anesthetist will come and the central line will be taken, till then we can definitely transfuse without any fear of over-transfusion in this case.
Yes. You're right.
Correct. Now, what will be our therapeutic goal with this? All the fluids transfused and the products which we are giving, what should be our therapeutic goal? Dr. Naresh is there. Dr. Naresh is there. Dr. Naresh.
Yes, sir. Actually, in this type of situation, sir, always in our labor room, I ask always my anesthetist to see all the vitals and they manage. If anesthetist is not there, then I advise for expert my staff. Advise my expert staff to do these all the things. But I always first see the where the blood comes. I always see the lower part of vagina and upper part of vagina, as well as cervix, and I manage according to that. It is a traumatic or atonic.
No, it is not. It is the monitoring. You have to answer about the monitoring and investigation part.
Yes, sir. I always give my all means. First of all, the blood coagulation profile and always D-dimer. Always in this type of situation, I always expect that after the severe shock and we give the profuse blood transfusion, this type of patient may go in DIC. So
is
always
it four, the standard protocol of 4:4:1 or 4:1:1?
What's that blood?
FFPCR.
In this type of situation, if whole flesh blood is available, then always I advise to give the fresh whole blood. And otherwise, if the fresh blood is not there, then I always prefer PCV as well as PCV and platelet, and there's the plasma. These all types of combination therapy I give to that patient.
Any other eminent panelists would like to add to fresh blood or PRBC?
No, it is not recommended. It is not recommended.
No, now we have people from periphery also, and they may not have components available for them.
Okay.
For them, it will be whole blood. Otherwise, we should avoid transfusing plasma, and we should remove and give RBCs only as long as possible.
Correct. Right.
Okay, sir.
So Naresh, with this, can you just elaborate about the MEO score, modified early obstetric warning score, which can give us the idea about the severity or the alarm bell when to be raised again? Dr. Naresh?
Yes, sir.
Can you elaborate about this MEO score, modified early obstetric warning score, as you said that you will ask your staff to look for the vitals?
Actually, particularly the score I don't remember, sir, but I always put my Foley's catheter and you see the urine output. At that time, pulse BP, it is increase or decrease, and the paleness of patient and the gush of blood I watch always in labor room. Okay, after this type of treatment, if patient is improving or not, it always show me the blood pressure and pulse, tachycardia and hypotension. If that improve and with no bleed, then I always suspect this my patient is improving in stage. And always I ask my anesthetist to see the saturation of that patient, as well as if any requirement of any adrenaline or noradrenaline.
Dr. Naresh, you very rightly said that, and as you rightly said that you should instruct your staff. So that's why in communications first slide, I insisted for the one of our staff should keep on recording or communicate properly.
Sir, one thing I add, always in this type of emergency situation, always I ask my staff, you always ask your relative of that patient, come on my consulting room and an audio recording all the situation. For 1 or 2 minutes, I explain that patient and patient's relative as more than 5 to 6 relatives with one staff, and I record all the things in my mobile.
That is from medical legal point of view, which is very important to save ourselves.
Yes, always.
Now, Dr. Neetaben, ball comes to you that now all the things have been done. Now, which are the measures you will like to do for the arrest of bleeding? Pharmacological measures.
Pharmacological oxytocin first. Nowadays, if the
you can just elaborate more into the doses where you at what doses you will like to give it.
Carbetocin 100 milligram IV stat can be repeated after 1 hour or so. Mostly the carbetocin 100 milligram.
100
and
micro,
if it is not available, the oxytocin, pitocin is the good option. The second one is, of course, the
here I will like to ask you that all panelists also can share their experience that if because active management of third stage of labor was done, oxytocin was given 5 minutes, and still it has bed with the atonic BPH. Does carbetocin helps after giving oxytocin?
It might not, because of their site of their receptor is somehow blocked, and they maybe it might not be that effective. But
And the
then
second thing about the
best
carbatos.
option is misoprostol sublingually or per rectally. That is to be given. Usually 600 milligram is a good dose. That is the second good option.
Misoprostol 600 microgram, carbapros 100 microgram.
Yes. And if at all you are going for carbetocin, I was talking about, and carboprost,
I think
if you are
carbetocin is
giving
not recommended for the
250
treatment of PPH.
That's what.
Carbetocin is recommended for the prevention of PPH. It is not recommended for the treatment just.
And I think it is the single dose which is to be given for the prevention also. The repeat dose of carbetocin is not advised.
Yeah, there is
after
no
4 hours
role
you
at
can
present.
repeat. After 4 hours you
Arul
can
bhai, what is
repeat.
your opinion?
As of today, it is not recommended to repeat carbetocin. It is one-off, just one injection, and that is why we use it for prevention. Now, one more thing is that oxytocin works faster than carbetocin.
Yes.
Okay, even if you give IV, oxytocin works within 5 to 10 seconds. Carbetocin takes 20 to 25 seconds. So even for prevention, I have a mixed protocol that I first give oxytocin bolus, IV, and then intramuscular carbetocin, which will act for 4 more hours. That is how I do it in cesarean sections. And one can do various combinations.
I
But
think many gynecologists up till now were using prostodin IM and oxytocin IV bolus for the prevention of PPH. Prostaglandin or rather carboprost can be replaced by carbetocin. Can be replaced by
carboprost is excellent medicine, but it is reserved for PPH and not for prevention. The reason is it can cause rigors and vomiting. And that is why we reserve it only for therapy.
And you have to be careful for the bronchial.
But I don't feel that rectal misoprostol for a therapy. It is for prevention. When we are already stuck with a PPH, then perhaps it is very slow acting and it will take long time. So
at the consultant level, it is not a role.
Methergine is a good medicine.
At the level of
I think we can start 40 units of oxytocin in 500 ml of NS and then start so that higher dose of oxytocin may help to control the tone of the uterus.
And Methergine can also be used. It is a good medicine for actual hemorrhage, not for prevention.
Right. But the first two things which we should not forget that you have to keep on doing that bimanual uterine compression and Foley's catheter should be in the place so that at least wool bladder does not interfere with the tone of the uterus.
And one slide did mention the use of tranexamic acid, which is a wonderful drug and it should always be used, I believe. Whenever, there is a higher than normal bleeding, first line therapy would be tranexamic acid.
Correct. I think Dr. Ratnesh Rohan
And when you were discussing the scoring system, there are 2 types. One is yellow alert and another one is red alert. So if the breaths are 15 to 30 per minute, then it is a yellow alert. And when it is more than 30, it is usually red alert. And when the oxygen saturation is up to 95%, then it is red alert. Less than 95.
And the purpose of bringing this chart here in the slide was that we should be very, very cautious about our vitals. Keep your eye on vitals every 5 minutes.
So you have to monitor respiratory rate, oxygen, temperature, systolic, diastolic blood pressure, heart rate, and neurological response as well.
Yes, orientation of the patient.
So Manoj, it is an excellent way of monitoring patient, but when we are talking of a single person hospital
managing,
then all this becomes infructuous, and then that person's personal management and his own
perception,
thought process would work. So that is a different situation, and many of the panelists, I believe, are having a solo nursing home. So for them, what would be the plan would be in order. So someone from you can share that how do you manage in your hospital, Naresh or Anand or someone.
Yes, sir. Good evening, sir. Dr. Naresh.
Yes.
In this type of situation, yes, sir. In this type of situation, when severe PPH occurs, in my hospital, always I call senior gynecologist for help.
I
always call,
yes.
and after that we get together and we may start at that time. Before my senior comes in my hospital, all the routine pre-op investigation, all in blood bank. I always told in blood bank this type of blood, this is my blood group of my patient. You keep 4 to 5 without replacement. Don't hesitate to replace the blood in for relative to give, even for the cost of money or even with the replacement. Always I told my blood bank people, you give 5 to 10 people without hesitate. All the things I manage after my patient survive.
That's a good communication and good relation.
Yes, sir. And always at that time, always keep 1 to 2 staff, active staff in my, even my own staff is not there. Then always I ask my lab technician, give 1 or 2 active person in my hospital at that time. And always I ask 1 or 2 another paramedical staff, can you present in outside, you see the situation from outside, and 1 or 2 more colleagues, 1 or 2 paramedical staff to keep all the situation, and they help me in this type of outside management.
Correct.
Inside management, always we keep with 2 gynecology go together, then we keep echo, and 1 anesthetist, always I keep 1 anesthetist. And according to situation of PH, we always decide 1 by 1 step. We explore routinely, we give all the medicines, IV medicines, and then intramuscular, whatever the routine protocol of PPH. But if patient, if the condition is worsen, then at that time 1 gynecologist always go below, means at perineum. And see
the teamwork should continue with all the resuscitation monitoring treatment together.
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Here I would like to add one more thing.
Okay.
That is, if there is any laceration like cervical, tear.
We are not,
or
Nitaben, we are talking about atonic BPH only just now. It was confirmed that there are no lacerations.
But sometimes it is combined. Sometimes you have to make sure
exploration,
that you are not missing something.
Yeah. That is
Nita, your moderator is telling you there is no tear. So now let us go ahead from there.
So now I think, Doctor, for the next question, Ratnesh, Rohan or Shashwat is not there. So the question jumps to Dr. Viral, that after Nitaben has given all the pharmacological, she has taken all the pain to give pharmacological measures to arrest the bleeding, but still bleeding was there. So would you elaborate about the mechanical measures to arrest the bleeding?
Yes.
Dr.
Yes, sir. Yes, sir. Good evening.
Yes.
Manoj,
good evening.
Arun, sir. Sir.
Sure.
Yes, sir. Yes, I will try first the removal of clots. If because you have right in the starting there clots in the vagina.
Yeah.
So I will try to remove clots from the vagina and from uterus if possible. Then by manual pressure after emptying bladder with catheter, by manual pressure. And
so Viral, can you highlight how would you get bimanual compression?
Yes, sir. One hand on the abdomen, left hand, and from right hand from per vaginal with a fist. So we can compress the fundal area of the uterus.
With the fist in the vagina, you lift the uterus.
Yes, sir.
And it is folded in front of your hand with the abdominal hand. So you are squeezing the uterus between 2 hands. So that is important. Just 2 fingers in vagina is not adequate.
Yes, sir.
And here, Parul bhai, I will like to add one more thing, that it depends on your handedness also. If you are left-handed, then do it with your left hand. If you are right-handed, because that power will help you to compress it properly.
Yes, sir.
Okay. So compression, what else?
Yes, sir. We are packing of uterus also done.
Packing is now not advisable by WHO.
Okay, madam.
Any of these balloon tamponade method which anybody
yes, balloon is good. Bakri balloon.
Yes.
Or maybe just a
condom
balloon. Yes.
So what is the difference between a balloon and packing?
Dr. Bharti, would you like to intervene?
Yes,
Yeah,
sir.
yeah.
Sir, I would suggest the intrauterine suction cannula that is available now, which is a very easy option, very excellent rather than the balloon tamponade and the other things. Just have it on your labor table always in all cases. And even if there is a mild PPH, your staff can be trained even before you reach the setup if you're not there. Just put that suction cannula and connect it. It is giving excellent results and it is
Because with the negative suction, I think all cervical tissue, it gets stuck to the cannula.
Yeah, the uterine tissue, sir, it contracts.
yeah.
Uterine contracts in the blood
Correct.
vessels, and that is an excellent tool. I think all of us should have in our labor room and in the operation theater.
Can you elaborate about the duration of time? For how much
Sir,
time?
we have used it like even before you suture the episiotomy. If you feel there's a little excessive bleeding, you've given your carboprost, you've given that, just put the cannula there. It can be held aside by the assistant and you continue the suturing of the episiotomy. And then you can release and see what the condition of the uterus. Is it atonic? If you feel at the site. In case it is PPH, after you finished your episiotomy and you're called back, you can insert the catheter and leave it, the suction tube and leave it there till the patient's vitals improve or you're shifting her to the operation theater. I have left it for more than 6 hours in 1 or 2 cases.
Oh, okay.
They've removed it. They say 30 minutes to 45 minutes is adequate.
The duration for which it should be kept is very important.
Yeah, that's about 30 minutes. But there are reports where you can leave it in situ till you organize the blood components. The patient is bleeding and the surgical intervention is going to take place. You can keep it till then. It does reduce the blood loss.
How much vacuum would you create, Dr.
Pardon,
Bharti?
sir?
How
We
much
use
vacuum?
Vacuum, I use it around 180 to 200 millimeters of pressure with the same vacuum setup which I use for my vacuum extraction of the baby. So we remove that cup and we attach it to this cannula. I'm not using it to the central line. I don't use it with the central line. I use it with this automated vacuum which has the pressure readings and you keep it there for 15-20 minutes, sometimes up to 30 minutes. But 1 or 2 cases I have kept it there. And few of my
Sorry.
Sir, in north, whether you are very familiar or not familiar, we are not sure. But in south, we have one is Dr. Vasudev Panikar's and second
Yes,
cannula,
cannula.
And it is available in all the government setups, sir.
Yes. And they are actively promoting them. And they have shown the maternal mortality incidence and PPH to has reduced to a very great extent.
Great.
No, it cannot reduce PPH, but yes, it can treat PPH.
It is the blood loss, yes, sir.
No, but it is the maternal mortality I'm talking about.
Yes. My little hesitation was it is a metal cannula and it may traumatize the decidua.
Yes,
and
sir.
So, a group from Israel are developing a silicone tube with the same purpose, which is
Now
flexible.
we are having silicone also nowadays.
Sir, I have an addition. One of our colleagues, we had an innovative methodology when a patient landed up with PPH and he didn't have the cannula, the Samartham's cannula. So he used the Eurosac, the tube of the Eurosac, or even the suction cannula of the MR syringe, the big number, the one. You can even use that. If it's the Eurosac bag, you make like the drainage tube, you just cut 2 or 3 windows on the side of the tube, place it inside and connect it. That also helps if you're apprehensive about
in dire emergency, what you say is very correct.
Yes,
just like we keep it after laparoscopy in the
exactly, sir. Exactly like that.
Something should help.
Okay, and now Dr. Neeta, can you tell us?
Perforated?
Sorry, Dr. Neeta Ben. Your experience with the balloon tamponade, for how many hours would you keep it for to achieve hemostasis?
Actually, it is ideally to be kept at least for 4 to 6 hours.
Okay.
Till you really find out that whether the patient is responding, or are you means if you are in a primary or secondary care center, then till you are shifting the patient, you may shift it with balloon itself in situ. And also advise the, make sure that you have those compression garments if it is available.
We are coming to that. Garment while shifting the patient, but at present it is the mechanical method. Parulbi, any comment about the rush balloon, which urological people use it?
I mean, see, basically the principle
remains the same.
Pressure. You want a pressure on the myometrium,
Yes.
and also not too much of pressure because we want it to contract also. So if we press too much, it will go into relaxation mode. But let me share with you one more thing. 4 to 6 hours may be too less. If your patient is settled, keep it for at least 12 hours or overnight. Why I'm saying this is, I did a workshop in the SRM hospital, Chennai. What is it? SRM is
Sri
yes,
Ramachandra.
Sri Ramchandra. And in that, Dr. Jaya, who was my senior colleague during residency, she was the professor. And in one patient, it was placenta previa, and she was bleeding after the surgery. So I packed with 2 mops, the lower side. Patient was settled. And I was leaving for my flight in the evening. So she said, no, before you go, remove the mop. So at 4 o'clock, we removed the mops and she started bleeding again. So I had to hold back and then put the Bakri balloon. Then she was fine. So when you pack and patient is settled, don't be in a hurry to remove it.
Exactly.
Let patient fully settle and then only try and remove it. This is the only point.
There is no harm in keeping.
Yes.
You know,
Yes.
if you have kept it in the
Yes, beyond
correct
24
condition.
hours, one should not, because
Yeah,
then infection is a worry. But
Very
up to
true.
12 to 14 hours, I believe, should be a minimum.
Now, Akshay Bhai, the patient comes to you after Dr. Viral, that went to you. Dr. Akshay Bhai?
Yes, sir.
Akshay Bhai, आपको आवाज?
Yes, sir.
अच्छा, so when to use non-pneumatic anti-shock garments, and just elaborate about the surgical methods to arrest bleeding.
So first, I don't have any knowledge about the pneumatic pressure compression devices because I have never used it.
Okay, we would like to have it from other panelists if they have it, or Parul Bhai or any our expert commenter. But still, before okay.
FIGO had proposed to give pneumatic trousers to all societies of Foxy. And there was a situation where societies had to write to Foxy and they would have been given this. Unfortunately, some midway then the corona struck and the project was stopped on the. So maybe we can try it again also.
And basically it is required when you are transferring the patient to a higher center, so that it can definitely help to maintain a good.
Mainly it is for transportation.
Transfer, correct.
And,
Akshay Bhai, having your sorry.
In
Dr.
addition to military anti-shock trousers, it has a abdominal pressure also to squeeze the uterus.
Correct. Akshay Bhai, having your experience at SVP and VS Hospital, just elaborate about the surgical method of your choice to control the atonic PPA.
Yes, sir. So there are so many methods all of us are aware, starting from simple uterine artery ligation that definitely helps a lot. Bilateral uterine artery ligation, right?
Yes.
Hello, am I audible?
Internally.
Yes, yes.
Yes, you are audible.
So stepwise devascularization definitely helps. So uterine artery ligation, then uterine branch of ovarian artery ligation. If needed, we go to the intrailiac artery ligation. And not to exaggerate, but I don't feel that intrailiac artery ligation is a very difficult method. Of course, we need to learn from seniors like Parul Bhai sir. And if it is rightly learned, then it can be easily applied. So everybody should learn it. In the methods, the combination method of B Lynch and uterine artery ligation that Mahesh Gupta sir has
that is
devised,
Comok MG Suja, yeah.
That is also quite effective. At this point of juncture, I would like to say one thing. Having a very small experience, but for B Lynch, in one patient, the stitch was taken with delayed absorbable suture material Vicryl, and to our surprise, after a few days, the entire uterus sloughed off, and in ultrasonography there was no uterus.
Oh.
Of course, we cannot put comment by saying one case, but of course that one case is important case. So in that perspective, I would like to say one thing, that whenever we try B Lynch, I think that is my opinion. Of course, the seniors people will have their inputs, but it has to be done with chromic catgut. I know that Ethicon is no longer being manufacturing this chromic catgut, but yes, other company chromic catgut is available and it should be preferred. As far as I know, Parul Kotradawala sir has personally probably met or had a telephonic talk with B Lynch himself. He would definitely like to throw his opinion on that. So that is regarding my individual experience on stepwise devascularization or surgical methods for control of PPH.
If hysterectomy needed, total or subtotal?
Atonic obviously subtotal, sir. There is no need for total hysterectomy.
Okay, fine. So now we come to the next section. Dr. Anand, MC Patel, he mentioned about the rule of 80%, where he said that 80% of the litigation cases are against the obstetrician. Out of those 80% are because of the previous, or rather for the cesarean operation. And of those cesarean, 80% are because of the hemorrhage. Now, from medical legal point of view, Dr. Anand, tell us the importance about the debriefing about this scenario to every to patient and patient's relative, and mention about the accurate documentation to avoid the future.
Let me intervene a little bit because Akshay spoke about a few things. I think I should also add to it. One is that not only one case, many cases are reported in literature where the sloughing of uterus has happened. Secondly, whether you use Vicryl or chromic catgut, within 48 hours, the uterus has reduced in size, so suture becomes loose. So it is not the suture, but the primary suture was very tight and it prevented the blood flow to the middle part of the uterus. And that is why, because of the continuous involution, within 2 days, the sutures are going to be very loose. So that doesn't really matter. Secondly, if you look at the blood supply of uterus, the uterines generally give majority of blood supply, but the blood supply of ovary. The ovary gets most of its blood supply from ovarian vessels, and so ligating uterine is not a problem. But at least 5 to 7% of ovaries get their entire blood from uterine only. Nothing is coming from ovarian. This has been confirmed by various vascular studies. 50% coming from both uterine as well as ovarian. About 40% entirely from ovarian, nothing is coming from uterine, but 5 to 7% gets entire blood flow from uterine. And if we ligate uterine, that ovary is likely to go into failure. And
But
so
in such
uterine
crisis,
ligation should be reserved only as a life-saving measure. See, sometimes people are doing it as a prophylactic. In a placenta previa, they ligate the uterine and then open the uterus. Don't do that.
At that time, it will be affected.
Actual PPH, you are saving the life of patient, you take that risk of
And it doesn't matter. Yeah, definitely. So, Dr. Anand?
Yes, sir.
Tell us about these two issues.
Yes, actually, when we are suffering from this, any kind of mishaps like PPH or anything else, actually, we have to keep one of the educated patient's relative with us. When we are doing all the resuscitation measures, immediately we have to tell them each and everything what we are doing. We have to show them what was the vital parameters and how they have improved, how we have tackled all the things, how we have taken a help of our colleagues and senior members, and what was the reason for having this atonic PPH and what we are doing it at what stage. Every time we have to take photographs of our vitals, how they have improved over the period of time. So definitely we can write it down later on when we get free. And
I think now with the NIBPN monitors available in say even nursing homes also, monitor have got a stored capacity where you don't need to take the photographs all the time.
Yes, but that becomes very easier when we take a photograph at the time, that you can plot it easily when you do a post-natally that documentation of all the records. So that we have to brief all the times with the person who is attending the patient, as well as the important persons from the family who is going to take a decision about whatever steps we are going to take. Suppose we are taking a patient to the OT and we are going for a plan for a surgery like devascularization and hysterectomy. In that case, we need to communicate all the treatment protocols to their close relatives like husband or their father and other relatives also.
True.
So accordingly, we can go ahead.
Yes, sir. And even audio video consent can be taken, sir.
Yes, sure. Consent is a
Welcome,
must.
Dr. Shashwat Bhai.
Sorry, sir. Sorry.
We missed your experience
Sorry, sir.
expert comments for the entire PPH issue.
Array, sir. Please.
No issue. We will take it for next 2 cases.
Yes, sir.
So Anand, anything else to be added?
Yes, that consent was the video recording and consent was to be done.
Right. So now we come to second case. A 30-year-old lady, G4P2L2A1, underwent outlet forceps delivery for meconium distress, fetal distress in the meconium at 38 weeks. Antepartum and intrapartum periods were uneventful. Uterus well contracted and estimated blood was somewhere around 400 ml. In immediate postpartum period, patient complained of sudden onset of breathlessness, cough, and sputum mixed with little bit of pink bubbles. She was a book case where her BP was entirely normal throughout the 9 months, and she had a normal blood sugar level also. So on examination, Dr. Viral, the patient was, Dr. Viral is there?
Yes, sir. Yes, sir.
Okay. Okay, Dr. Viral, the patient was conscious but drowsy. 128 beat per minute was the pulse. BP were 90 by 50 milliliter of mercury. SpO2 88%. On auscultation, the chest was clear bilaterally. Uterus were well contracted and there was no active bleeding from the pervaginum. Investigation-wise, when she delivered, it was hemoglobin 10.4 gram per cell, 1.8 lakhs, normal coagulation. What is the probable reason for this crisis in the liver? We can't listen you properly. Dr. Vira?
Yes, sir.
I think somebody needs to mute their voice. Yeah.
That may be, sir, because you have pink frothing sputum is there. There may be fluid embolism or any unforeseen event may be there.
Okay. No, but without any cause, when such symptoms occurs, it is the diagnosis is because always the amniotic fluid embolism is a diagnosis of exclusion.
Okay, sir.
So when the patient is complaining of acute fetal compromise if not delivered, cardiac arrhythmia or arrest, coagulopathy, convulsion, hypotension, or particularly say shortness of breath, oxygen saturation declining, restless, agitated, then the first thing which should come to our mind is amniotic fluid embolism. Which are the risk factors we should keep it in mind when patient is admitted for the delivery for the amniotic fluid embolism?
Sir, it is difficult to pinpoint, but yes, there are definite high risk factors which we can keep in mind. That elderly gravida patient having multifetal gestation, polyhydramnios, case of cesarean section, case of instrumental vaginal delivery.
Exactly.
These are the cases which are, and cases of pregnancy-induced hypertension. These
Correct.
are the patients who are more prone to develop. Of course, it is very rare, but they can.
So when these patients developed sudden shortness of breath, oxygen saturation was less. So what are the hemodynamic changes we are expecting in this patient in next few minutes or hours?
Sir, there will be tachycardia, hypotension, and hypoxia.
Correct.
Yes, sir.
And anybody else want to add to it?
Yes.
The patient may go for DIC.
When the patient serves DIC.
Step coagulopathy and DIC and PPH can be there after some time.
Correct. These are the complications which may lead after the amniotic. But initially, there is always a biphasic response with the amniotic fluid embolism, where there is initially pulmonary hypertension and right ventricular failure, and later on patient goes into the left ventricular failure and then death. So the first thing will be respiratory and circulatory disorders which will occur. Then coagulation disturbances will start, and as a complication of it, there will be acute renal failure and ARDS leading to cardiopulmonary collapse. So, Anand, just let us know which investigation.
One thing, sir. I heard you.
Yes.
Pardon me?
Hello, sir.
Yes.
In peripheral level, sir, actually at the night time of labor, these are all things in multi-speciality or in medical college resident is there. But in our setup, sir, we run as a small unit. So always we keep the patient after delivery 1 hour at night time, always in labor room, and then we shift the patient. This is routine protocol we
I think it will be the same protocol in even in nursing homes in Ahmedabad also.
So we keep for 2 hours.
2 hours.
2 hours. Yes.
In labor room,
Sir, I would like to
Next
say
to the
one
labor
thing.
room, we have an observation room. And
Okay.
we keep them there for 2 hours.
And relatives are there always with the labor.
Yes, one relative will be there, and the baby also will be with them.
Okay.
Sir, I fully agree with madam. Even recent textbook suggests that for 2 hours, every 15 minutes, vitals should be monitored.
Yes.
Every 15 minutes.
That is the observation. Yeah.
Yes, sir. And one point I would like to add, sir. In few references, they have written that the sometimes excessive fundal massage or fundal pressure when given uterine massage can cause embolism.
Okay.
So it's not proven, but they have written one of the etiological factors, sir.
So even though you are carrying out the AMTSL active manager third stage labor,
Yes,
it has to be very cautiously done.
Yes.
Correct. Now, Dr. Anand, can you tell us the investigation which are needed for suspected case of amniotic fluid embolism?
So besides complete blood analysis, we have to do for a blood gas analysis. We have to look for X-ray chest, ECG, pulse oximetry, and 2D echo of this patient. We have to see for the LFT, RFT coagulation profile and all this, and that may help us in diagnosing the
Right. So as such, there are no specific tests available for making the diagnosis of amniotic fluid embolism, but we are advising or subjecting patient for the investigation because of the system which are affected because with embolism. So now, Dr. Naresh, can you?
Most common is the peak sputum that is signs of pulmonary hypertension. So definitely the diagnosis might be of a amniotic fluid embolism.
High index of suspicion clinically.
High index of suspicion, exactly. And as such, it is a diagnosis of exclusion. So you have to exclude everything else and suspect it.
Yes,
Dr. Naresh, just tell us about the treatment goal you will be planning for a patient of amniotic fluid embolism.
Sir, actually in embolism, it is such a type of emergency crisis. Always we start from ABC, and at the time of always put the oxygen. Always I call my anesthetist, and I always start my staff to start routine management of IV line, as well as to see the means oxygen and routine. And for the hypotension, always I start the available for to prevent the hypotension. I start with Norepinephrine. And at that time, I always in pulmonary embolism, I always actually in my life, I never come across this type of situation in my hospital private setup.
That's good.
But and thank God, sir.
Thank God.
But always keep I call my anesthetist to keep this type of patient after given some primary treatment in ICU setup. In private setup, sir, this type of patient is we can't able to manage in our own nursing room.
See, it is not about the because these are the crises which happens in any labor room at any fine day or any night. So then we have to manage and then we have to decide what shall we do.
Yes, sir. Oxygen and IV line.
Once patient is shifted to the multi-speciality and intensive takes over our case, then our half of the job is done. So till patient is shifted, what we shall do? That is most important. So that is oxygen and preload optimization. So you have to give the good circulatory volume with the whiteboard needle.
Yes, sir. Only that thing we give.
And then if complication like coagulopathy has occurred, then correct with the PRBC.
Yes, sir.
Which is very required to correct to restore the oxygen carrying capacity also. And if platelets FFP is needed as condition demands, we can give it. Now, Dr. Neeta, can you tell us about the how managing hypotension? Dr. Neeta Ben? I think she has gone. Okay. Dr. Viral, you can take over that.
Yes, sir.
Yeah.
Managing hypotension, rapid infusion of the fluid via bore IV line, and if blood pressure is still down, we can add a dopamine and norepinephrine. Blood component we call for blood pain or blood component. Yes, if there is a coagulopathy, and oxygen.
And once the patient is shifted, intensivists do try this nitric oxide inhalation, prostacyclin or sildenafil to treat the right ventricular failure. or pulmonary hypertension which occurs in amniotic fluid embolism. So now that is the thing which we discussed about them. Anybody else would like to add expert comments for amniotic fluid embolism?
Sir, I would like
For
to
the
say
fluid, yeah.
This is the third case.
For the
This is the
fluid,
third case we are going to start, but till then, for the second case. Yeah, Kaushik bhai.
Yeah. For the fluid management, what I would like to add is initially, yes, crystalloids to correct the hypovolemia, but usually these patients will after develop ARDS. So after the correction of blood pressure, systolic blood pressure, we will have to restrict the fluid according to the CVP line.
Agreed. Absolutely. So it is optimize the pre-overload. That is the word which is required to maintain the circulation.
Sir, I would like to say two more things for amniotic fluid embolism. One is when we are doing cesarean section or when we are taking episiotomy and we see the change in color of the blood, we should suspect amniotic fluid embolism. So that is one thing.
And
I think change of color in cesarean with high spinal also does occur, Akshay bhai.
Yeah.
When there is a high spinal and patient has got breathing difficulty,
So any hypoxia. So any hypoxia, right?
Yeah. So that is because of the hypoxia. We should suspect hypoxia rather than the amniotic fluid embolism.
Yes. But suppose we are
even peripheral cyanosis.
True.
Cyanosis also will help us. Cyanosis will help us. And another important thing is the DIC will develop even before the significant amount of blood loss. That is very important.
True.
DIC will appear before the amount of blood loss.
So always keep a close watch on the vitals all the time.
And there should be no fever. There should be no fever during labor. Otherwise, it will be a case of sepsis also.
Correct. I agree. We move on to third
in
case.
resuscitation, I'm sorry for the interruption. In resuscitation, immediate intubation is very essential if needed.
Correct. With endotracheal cough tube.
Yes.
At least LMC should be kept everywhere.
True.
Laryngeal mask.
Yeah.
And that can be done by everyone. Even still anesthetist comes, we can keep it. LMS.
True. LML. Yeah. And it will snugly fit over the larynx, and then you can give the oxygen.
Yeah.
So now we are moving to third case.
It should be a part of our emergency kit.
Kit. The third and final case was sudden maternal collapse, where a 26-year-old lady G2P1L1 with 36 weeks of period of gestation was admitted in an emergency in labor room with abdominal pain, severe headaches in 6 hours at home. She was lost for the antenatal checkup since last 3 months. So as far as severe hypertension management was concerned, it could not be done with the patient because she was not for the antenatal follow-up. On admission, she had pulse 110 beat per minute, BP 170 by 110. Respiratory rate was 22 minutes with edema fit. Fundal height corresponds to period of gestation. The fetal heart sound was 138 minutes per regular, but 38 per minute regular. Within 10 minutes of admission, she got convulsed before we can start the management, and she became unconscious. So now, Kaushik, can you define what is a sudden maternal collapse?
Eclampsia.
Yeah, it is a
the definition
sudden maternal collapse. It is an acute onset of cardiorespiratory or CNS event during pregnancy.
During the or in the correct, and
which will result in the alteration in the consciousness level.
Correct. And if not treated properly, it may end up with the death also. Now let us know the causes which are responsible for the sudden maternal collapse. Kaushik bhai.
Usually the causes are in the form of 4H, that is hypovolemia, hypoxemia, hypokalemia, or hypothermia. But these two are very rare. Hypovolemia and hypoxemia are more common. Fourth is in the form of thromboembolic complications, maybe pulmonary embolism, aortic fluid embolism, or in the form of air embolism. It can be a tamponade due to cardiac causes. It can be due to tension pneumothorax. These are the cases of accident, or it can be due to the substance abuse. And toxicity of the drug can be because of local anesthetics or can be because of substance abuse. or rare causes, the causes of obstetric causes like eclampsia and other rare causes are also there.
Eclampsia is the cause which we come across regularly where we are managing the patient.
Yeah.
Akshay, just
cardiac causes are very common. Cardiac causes, cardiomyopathy is very common, and cardiac tamponade. It may be aortic dissection. It may be dissection of the coronaries as well.
Correct. Though we take all
due to the rupture of the hepatic. Hepatic or splenic rupture also.
Dr. Akshay,
looking at the history here, there is a classical case of eclampsia, and the patient went into yes.
Yeah. Akshay, we just will like to know from you that though we take all the precautions that there is no mistake as far as drug is being given during the labor room in an emergency. But can you tell us something about the drug misuse?
Yes, sir. Sometimes what happens that because of similar looking ampules or relatively new staff or untrained staff, because everybody can't afford a trained staff. I'm sorry to say that.
No.
So by mistake, instead of giving atropine, some people have given adrenaline, and that has caused a chaos. So that has to be, so similar looking ampules or bulbs to be discriminated or kept separately, and the emergency drugs should be kept in a separate box or a separate tray that should not be handed to all the staffs.
Correct. And the onus lies on the doctor also when there are two same similar looking ampules or vials. We should change the brand.
Yes, sir.
So that if we change the company, then there is no similarity in the appearance as far as drugs or vial or ampule is concerned. So we can minimize.
Pandya sir, actually, in that condition, actually always as a peripheral level, we always keep one standard protocol for that injectable medicine. We never change frequently injectable medicine.
Agreed.
Only when patient we call gentamicin bulb, then patient staff, even our IABN always keep the gentamicin. The look is same since 4 to 5 years. No change in color as well as the size of ampule, sir.
True, but in between ketamine and gentamicin bulbs were looking the same, and there has been instances where ketamine has been given instead of gentamicin.
But yes, sir. But always we for anesthetic drug always keep in custody in one box particular. Never we put in labor room.
They say ketamine is being used as for the obstetric analgesia also. So it is not an anesthetic.
But sir, in that situation always we keep one separate box. Adrenaline, atropine, and ketamine. Always we keep and thiopentone and propofol. We always keep in one separate box, not mixing in other medicine.
Okay, right. Now, Dr. Naresh, just tell us about the immediate action you will come into with the sudden maternal collapse. Dr. Naresh.
Okay. Yes, sir.
Immediate action when sudden maternal collapse.
Actually, when we come across this type of situation, sir, always routine management for ABC means airway, and there's all the IV lines and all the routine medicines. And senior obstetrician, anesthetist, and pediatrician. If babies for care of baby, always
in this case it was 138 per minute when patient was admitted. Fetal heart rate was 138 per minute.
And always in my routine practice, always I keep pediatrician always present in my labor room at the time of second stage.
Correct. I think all the obstetricians have agreed to that protocol now with all the deliveries and cesarean.
All not even normal labor, sir. I always, frankly, I come sometime 5 minutes late, but when baby come out, my sister doing late, then always pediatrician there. I come up, I go there in labor room after 5 minutes of labor.
Okay. Now when Naresh has told about Nitaben is not there, I think. Yeah. So now Viral, when Naresh has told about the ABC approach, I would like to know from you that what airway care and actions required for when breathing is present, because there might be two conditions with the collapse: breathing absent, breathing present. But when breathing is present, and what airway care will you take, Dr. Viral?
Yes, sir. When always we keep the airway in between in the patient's mouth, and always put the oxygen in the that airway. And if a patient is breathing is not there, then always we try to intubate. If possible, with ourselves.
Breathing is not that we are coming to Dr. Viral and Naresh. You rightly told that make a airway clear. If there is an obstruction, clear it, head tilt, and chin lift so that at least airway becomes patterned. And you should assess the breathing for 10 seconds. So chest with the chest movement and the breath. Now, Dr. Viral.
Yes, sir.
When breathing is not there, what will you do? When breathing is not there, cardiac arrest, sudden collapse has occurred.
CPR is given.
Yeah. Now just elaborate about the CPR. Which thing first?
Breathing is absent. Circulation is also important. CPR with uterine tilt. 30
uterine
chest
tilt, how many degree? How much uterine tilt will you do that? Akshay bhai?
Hello. Yes, sir.
15 to 30 degree.
50, yeah.
15 to 30 degree.
Correct. Okay. Okay. Go ahead, Viral.
Yes, sir. Depress the 5 to 6 centimeter at center of the chest. Then for ventilator.
No, it is not about the ventilators. When you are doing the CPR, that should be a 30 chest compression. It means in 1 minute, 2 chest compression has to be there. That fast, effective chest compression should be carried out. And it's a team approach. And then at that time, after each 30 chest compressions, you have to give a 2 ventilation or say with the for the oxygen. Ventilator, so till ventilator is started or defibrillator started, before that we have to come into action for the CPR. So Dr. Shashwat bhai, which are the actions needed simultaneously along with the CPR? Shashwat bhai? I think he has gone again. Okay, Akshay bhai, you can carry on, take on.
Yes, sir.
Sudden maternal collapse, breathing absent, and CPR is being carried out. So simultaneously, which are the things to be needed to be done?
So first of all, sir, we need to intubate. We need to maintain the oxygen near to 100%.
Correct.
So we need to find out the cause, and we try to
the cause was eclampsia.
Yes, sir. So we manage the etiology. So definitely our management is a standard protocol for 2 things. One, magnesium sulfate, and we need to take care of blood pressure.
Correct.
Then we need to see about the heart rate and blood pressure. And if there is a hypotension, we need to give dopamine or noradrenaline based upon the circumstances or requirement.
Correct.
Yes, sir.
Correct. And then adrenaline, if still the cardiac activity has not come, we can keep on giving adrenaline every 3 to 5 minutes.
Yes,
and atropine and magnesium as per our eclampsia protocol, which we need it. Now, what action needed, Dr. Viral, if still with the CPR, there is either asystole or there is ventricular fibrillation and ventricular tachycardia. So what will you do?
Sir,
VFPT or asystole? There is no electrical pulse activity recorded on the monitor, or there is ventricular fibrillation or tachycardia.
Sir, how many questions are more, sir? Because we have one more lecture to be
This
done.
is last one. Last question about the perimortem cesarean. Then I will
Yes, sir. Kindly.
I will just finish it. This is the
Yes,
last
sir.
question. So the thing is that if there is ventricular fibrillation or ventricular tachycardia, we need to use the defibrillator, and there are no change in thoracic impedance during the pregnancy. So we can use the same energy level for the defibrillator shock as we are using it in non-pregnant patient, which is one shock is 200 joules biphasic or monophasic is 300 joules. And CPR, till that we have to continue the CPR in 30:2 ratio. Now, Akshay bhai, perimortem cesarean.
Yes, sir. So no, to be very honest, no individual experience for the same, but yes, theoretically, yes, of course we can do it, and we should do it. If it is done within few minutes, then we can survive the baby, and that can be done on the on the site. We don't need to even take the patient to operation theater.
Correct. So these are the guidelines which has been mentioned that if there is no cardiac output in spite of repeated CPR by 4 minutes, regardless of the fetal condition, it is not for the, but interest of the mother is first, because many times once you deliver the baby, that aortal compression may reduce and it may help with the CPR. And the only thing which you require is sterile scalpel bed and cord clamp. But you have to continue continue CPR throughout the surgery when you are doing a perimortem cesarean. So thank you very much, all the panelists. I thank organizer of the Happy Learning Masterclass series, SOGOG in association with all the 5 societies, Program Director Dr. MC Patel, all the 3 conveners, Dr. Akshay, Dr. Sneha, Dr. Asha, my co-moderator Dr. Kotrawala, who gave me all the liberty to cases the way in which I wanted to do. I'm sure I have come to his expectation and Dr. MC Patel's expectation.
Yes.
I thank all the esteemed panelists, expert comment given by Dr. Bharti and Dr. Rekha. Last but not the least, the coordinator, Dr. B. Kalpana Jyoti, and MOC, Dr. Suman. And we thank Corona people for the sponsorship. Thank you very much.
Thank you, sir.
Thank you. And the point which Manoj highlighted.
2 moderators and all the panelists. Yes.
MC led the
one point which was highlighted by Dr. Manoj is very important. Few patients have recovered because of that emergency cesarean section in the bone.
Perimortem.
Okay. So it did not become perimortem, but patients survived because that pressure of uterus was taken off and they recovered. So that is something which we have to keep in mind, that in desperate situation, we may deal with this. Yes, MC, sorry.
Dr. MC Patel, I will like to ask you
today only in other webinar, I was a guest of honor and I shared the same experience. Peri-mortem cesarean section. And incidents I can quote, which happened in Riva. It is in MP. Dr. Binu Kushwaha, HOD in Medical College, she did peri-mortem cesarean section. And luckily, baby and mother both were saved.
Oh,
so it is a very important decision, but very quick to take and very quick to
execute.
Execute. Dr. MC Patel, one medical legal question for the same.
Yes.
When the doctrine of best interest always prevails, so do we need to take consent for the perimortem cesarean?
If it is a dire emergency and if you can prove by your record that whatever you did was to save life of patient, no consent is required.
Okay, thank you very much. Thank you.
But again, word of caution, burden of proof is on your shoulder to prove. So your document should be updated.
True.
That what happened exactly time-wise and what you did. So it is very important.
Okay, thank you very much.
Yes.
Dr. Manoj and Dr. Parul, very nice interaction. Important clinical scenario you have covered, that too practical, emergency, and very, very necessary 3 important practical scenario you have covered. Thank you so much. Very useful.
I think Dr. Murugesh is still not seen. I think he was held up in one emergency.
Sir has messaged he has held up in the placenta previa.
Yes, placenta previa he was dealing with. So we can conclude, no issue.
We can take him for the panel discussion next time with placenta previa.
Day before yesterday, we had PAS webinar panel on PAS.
Actually, Manoj, just 2 days back, we had the same discussion and our title of webinar was the placenta, the magic organ.
True.
And it was with Baroda, Nadiad, Anand, Godhra and Bhavnagar.
Good.
So in adherent placenta, that is placenta accreta spectrum was discussed. Troubleshooting in placental abnormality was discussed. And my topic was legal issues in placental abnormality.
Correct.
So it was very nice discussion. And video recording is available if at all anybody is interested. All the recordings of all past webinar are available.
The first talk,
anybody can ask.
Sure.
First talk was on placenta and sonography. Second was PAS, and
so
third.
The specific topic was given to one of the faculty, the placenta and sonography. In sonography, what will you see as far as placenta is concerned? Was the topic given, and I had a word with him prior that I need only this one, nothing, placenta and sonography.
True.
And he justified the topic.
Okay.
He put many videos he put.
Yes.
Almost 11, 12 type of placenta and 3 videos of everything.
And even in that panel, they showed so many nice
Yes.
different kinds of pleasantries.
Nitin Raithata was moderating the panel with Pallavi Satarkar from Baroda.
Yeah.
So they justified their role.
Yes.
So should we conclude?
Yes.
Any final comment from Dr. Parul?
Yes, sir.
Parul bhai.
And we will conclude then.
Sorry, no, but I think we are getting quite late, so let us wind up.
Okay.
And both you and me are traveling to Delhi in the morning.
Yes, early morning.
I'm also traveling tomorrow.
At what time you are reaching?
For me, it is a routine. Every
About
Saturday,
10 o'clock, I should be in Delhi.
Sir, my flight is
every Saturday, Sunday, I am traveling somewhere.
tomorrow. Our flight is 5:30. 5:30 is our flight.
Become routine.
Wow, so you better go and sleep.
Mine is 1:30.
So, Nilesh?
Patel, sir.
Yes.
MC Patel, sir, and Parul Kotdawala, sir. We learned a lot of things in this today webinar, sir. Thank you very much, sir.
But Naresh, we can give you a link of our webinar, and once you register, then you are automatically registered for all the incoming Happy Learning Masterclass web series. And
Yes,
we
sir.
usually go with focus topic. Today it was mixed bag. Otherwise, usually we go with focus topic. Say, for example, next Tuesday, we are with the Societies of Odisha, and we are going to discuss about obstetric injuries.
Yes, sir.
And then after we are with North Delhi, stillbirth. So
Okay, sir.
exclusively on stillbirth we will be discussing.
Okay, sir.
So you can join any Tuesday.
બહુ
It is our
મજા
continuous
આવી
series.
સાહેબ. આજે પહેલી વાર એવું લાગ્યું કે પાછું કોલેજમાં ભણવા બેઠા હોય ને એવું લાગ્યું સાહેબ. 6 વાગે ઓપીડી.
આમાં છે ને તમે એક કે બે લાઈન પણ આમાંથી પિકઅપ કરીને તમારા પ્રેક્ટિસમાં વાપરો ને.
બપોરે સાહેબ ગેપ નહીં પડે.
અમે તો એવું કહીએ કે even if with line of any of our webinar, if one patient is saved, it is worth.
That is worth.
Our webinar is worth.
એના માટે સાહેબ ઓપીડી માં ગેપ પાડ્યા વિના 6 વાગે 6:30 ઓપીડી પતાવી કન્સલ્ટિંગ રૂમ છોડીને ઘરે આવીને બેસી ગયો છું રૂમમાં સાહેબ.
Good.
નીચે બેઠા હોય તો પેશન્ટ તો હેરાન કરે.
And one more thing on behalf of Palanpur Society and Dr. Naresh Prajapati, President of Palanpur Society just now.
Yes, sir.
We are inviting all of you at midterm SOGO conference, which is going to be held at Mount Abu, but organized by Palanpur Society.
Yes, sir. Thank you, sir. Thank you,
most
sir.
welcome.
Thank you, sir.
Welcome. All the
MC date નક્કી છે?
Yes. 30th June, 1st, 2nd July.
30 જૂન પહેલી બીજી જુલાઈ સર કોટડાવાલા સાહેબ તમારો
બ્લોક કરી લો તારીખો.
No, there is a clash. There is an IAG conference in Chennai also on 1st and 2nd. That is why I was asking.
But we had planned these dates well in advance, and they have gone far ahead.
Okay.
As far as booking etc. at Abu is concerned.
Yes.
So now there is no scope of change of date.
કોટડાવાલા સાહેબ આવવાનું જ છે તમારે.
No, I have committed much earlier. Yes.
તમારું લેક્ચર તો સાંભળવું જ પડશે સાહેબ.
Right, Parul. If you can plan for one day or so, you can.
Yes. We'll organize some. આ તો ઘણીવાર last minute change આવી જાય છે ને date નો, એટલે I wanted to reconfirm.
No. And the same way in month of December, regular SOGO at Himmatnagar, it is also fixed. Time, dates, everything. Because we had a just meeting with Himmatnagar Society some 7-10 days back only. We had been to Himmatnagar from Ahmedabad, and we had a good discussion with all organizing team as far as incoming SOGO conference is concerned.
Perfect.
Last Wednesday only we had been to Himmatnagar. So in spite of all this commitment every Saturday, Sunday and Tuesday, we have to go for this also.
માઉન્ટ આબુમાં સાહેબ છે ને આપણે એન્ટરટેનમેન્ટ પ્રોગ્રામ પણ બહુ સારા છે, એટલે સાહેબ મજા આવશે બધાને.
બિલકુલ.
હા, મજા આવશે. Okay, sir.
So most welcome, and we can conclude. No issue.
Yes.
Thank
you.
you.
Corona Mitra.
So what about that another talk?
No, he stuck
is
up
tied
with
up,
emergency. a case of placenta previa. So
Oh, the
he
same.
unable to join
Okay,
again.
okay, okay,
And
fine.
we
Same
will
person.
conclude, no issue. We will
Okay.
conclude.
I thought some other doctor.
No, no.
Okay.
So, friends from Corona.
Yes, sir. I think there is no one. Nilesh. Okay, okay.
Yes.
Yes. We can conclude.
Thank you.
Yes.
Sir, Nilesh, are you giving to vote of thanks?
No, madam.
Okay. On behalf of Happy Learning webinar series, for this 132nd episode of Happy Learning, I extend my heartfelt thankful to Dr. U.C. Vasavda sir, Dr. Mahendra Soni sir, Dr. Kamini Patel madam, Dr. Atul Munshi sir, for gracing this webinar. Our esteemed chairperson, Dr. Mukul Shah sir, Dr. Pushpa Yadav madam, Dr. Sandeep Patel sir, Dr. Yamini Trivedi madam, Dr. Bhavit Shah sir, Dr. Sapan Doshi sir, Dr. Dignesh Bhalakia sir, Dr. Mukesh Savalia sir, Dr. Mukund Patel sir, Dr. Parul Kotrawala sir, and Dr. Manoj Pandya sir for giving the pulse of wisdom and sharing knowledge. All our esteemed speaker, Dr. MC Patel sir, Dr. Rohit Jain sir, and Dr. Mukesh Patel sir, I extend my heartfelt thanks. All our panelists, Dr. Anand Chaudhary, Dr. Rohan Patel, Dr. Ratnesh Patel, Dr. Viral Luhar, Dr. Neeta Thakre, Dr. Shashwat Jani, Dr. Akshay Shah, Dr. Naresh Prajapati, Dr. Kaushik Vyas, Dr. Gunjan Badrakia, and our expert comments from Dr. Bharti Rajshekar and Dr. Rekha Rajendra Kumar. I thank you very much, Madam, Rekha Madam and Bharti Madam. My Master of Ceremony, Dr. Suman Sinha Madam, I extend my heartfelt thanks. And my co-convener, Dr. B. Kalpana. And above all, I extend my thanks to Dr. MC Patel sir for giving us this platform. Thank you.
Thank you.
Thank you, Corona Remedies, for giving us this virtual platform. Thank you, Corona Remedies also. And good night, everyone.
Yes, Nilesh, we can conclude.
Thank you.
Thank you all.
See you all in Delhi. Parul sir, MC sir, Suman madam.
Yes, tomorrow only.
See you tomorrow.
Yes.
Bye-bye.
Bye.
After tomorrow, I think.